Let's start. Is my voice clear now?
Assalamu alaikum, Dr. Khalid.
Hi, Dr. Ruban. How are you? Alaikum assalam wa
Alhamdulillah,
barakatuh.
alhamdulillah. I'm fine, I'm fine.
Sorry.
Yes, yes, yes. Yes, voice is clear.
Okay.
Clear, Dr. Khalid. Clear.
Let's continue the third lecture, interactive session on the thyroid disorder. And this is a very important session because it contains hypothyroidism, and practically this is a very important issue. Let's start with our third session about hypothyroidism and of course amiodarone and so on. We will start from page 64 from Oxford Handbook of Endocrinology, and the third edition, by multinodular goiter and solitary adenoma. And of course this issue of thyroid cancer will be discussed in more details inshallah in the last session in the next Friday or the after 2 weeks with Dr. Ibrahim Al-Ali inshallah, when he will discuss differentiated and non-differentiated thyroid carcinoma. The multinodular goiter and solitary nodule, the most important highlighted paragraphs. Let's know that the prevalence is high. It ranges from 5 to 50% according to the method of detection of thyroid nodule. Is it clinically or by ultrasonographic guide or CT or so on? And of course, as we know, most of thyroid disorders is more common in the female. Thyroid nodules also more common in the females. And of course, the most important issue when we deal with thyroid nodule is to exclude thyroid malignancy. And of course, thyroid malignancy is less than 5% of all thyroid nodules. But we must know who is cancer and which one is just a benign adenoma. A clinical examination or clinical evaluation of thyroid nodule, we must take from the history what is the alarming manifestation, alarming signs or symptoms. Alarming manifestation which indicates that the risk of malignancy is high. So in any patient, we must take a history about previous history of radiation, neck radiation. History of exposure to radiation increase the risk of thyroid cancers, especially if this radiation intake in the childhood period. Also, family history of thyroid cancer, one of the alarming manifestation, and of course, the development of hoarseness or dysphagia, we must suspect it is thyroid malignancy. Nodules are more likely to be malignant in young patients, less than 20 years or 10 years, and also the new nodules which appears in the elderly people, the risk of malignancy is high. Thyroid nodules are more common in the female, but more likely to be malignant in the male. The risk of malignancy is similar in patients with single or multiple nodule. So in every case of multinodular goiter, we must deal with it as a single nodule and focus in every nodule and deal with it as a single nodular risk stratification. And we can do final aspiration biopsy from the most suspicious nodule or the largest one if no one is more suspicious. There are some of physical findings suggestive of malignancy, and this of course in every exam at least one question from the physical findings suggestive of malignancy, which include firm or hard non-tender nodule, recent history of enlargement, recent history of enlargement fixation to adjacent structure, or a presence of regional lymphadenopathy, especially if there is no preserved hilum in the lymph node, which is high suspicious of malignancy. There is a famous sign which is Pemberton sign. Pemberton sign means facial erythema or facial congestion with elevation of raising the arms, which means mostly superior vena cava obstruction, and this means a retrosternal obstruction by the goiter, and this is an indication to refer our patient to the surgeon. We must know that the hot nodule in the radioisotope scan make malignancy is less likely, but does not exclude malignancy by 100%. Still, a risk of malignancy is present, but it is low than if the nodule is warm or cold nodule. The etiology of thyroid nodule, the most common is the colloid nodule or cystic nodule, lymphocytic thyroiditis, pseudonodules, benign neoplasia like hair cell or follicular adenoma, and also malignancy is a papillary or follicular carcinoma, which is differentiated thyroid carcinoma. Differentiated thyroid carcinoma means papillary or follicular thyroid carcinoma. The uncommon cause of thyroid nodule granulomatous thyroiditis infection in malignancy, which medullary thyroid carcinoma, which is arises from C cells, and of course anaplastic and metastatic and the lymphoma. And don't forget that the lymphoma increase in a patient with Hashimoto thyroiditis. Anaplastic, this is the poorest one in the prognosis, anaplastic carcinoma, and the median life is 6 months after diagnosis of anaplastic carcinoma. And of course, the treatment of all malignancy is mainly surgery. But we must know that differentiated thyroid carcinoma, and inshallah with Dr. Ibrahim Al-Ali lecture, he will discuss it in more details. We must do surgery followed by suppressive therapy, for radioactive iodine, then suppressive therapy. Yes, Dr. Ahmed?
Is every case of Hashimoto thyroiditis must be operated for fear of lymphoma?
No. Of course, Hashimoto thyroiditis, the main treatment of Hashimoto thyroiditis is mainly medical therapy, no role for surgery. But if in any patient with Hashimoto thyroiditis and there is suddenly enlarged thyroid nodule, we must suspect lymphoma. There is alarming manifestation in his stable Hashimoto thyroiditis, we must suspect it may be a lymphoma, so fine needle aspiration must be done. And of course, lymphoma, treatment of lymphoma mainly medical, not surgical. Even if we diagnose thyroid lymphoma, this is treated by medical therapy, not surgery. Surgery just for papillary or follicular, which is differentiated medullary carcinoma, anaplastic thyroid carcinoma, but lymphoma, the first line of treatment mainly is medical therapy.
Okay.
There are a paper recently published in the Medscape for the patient Hashimoto thyroiditis who is still complaining after normalization of TSH after some period, and someone suggests that maybe a total thyroidectomy for Hashimoto thyroiditis may improve his manifestation, his complaint. But this study is not accurate to 100% because a lot of authors of this study is surgeons. They recommend, of course, surgery, and of course, no randomized controlled trials that recommend surgical management of Hashimoto thyroiditis is better than medical therapy by levothyroxine, even in those patients who are still complaining after normalization of TSH. Of course, the clinical feature raising the suspicion of thyroid malignancy, this is very important. Age in childhood or elderly, short history of enlarging nodule, local symptoms like dysphagia and stridor and hoarseness. This is alarming manifestation, or a previous exposure to radiation. And don't forget that exposure of radiation, atom bomb exposure, increases the risk of papillary thyroid carcinoma, which is the commonest thyroid malignancy. A positive family history of thyroid cancer or Menne syndrome increase the risk of suspicious of thyroid cancer. And don't forget that Gardner syndrome, which is familial large intestinal polyposis, increase the risk of thyroid malignancy. And Cowden syndrome, this syndrome is very important because in every exam there are a question about Cowden syndrome, and we will discuss it in more details in the next slide. This is very important because it is autosomal dominant. This is the first one, autosomal dominant, and affect multiple organs, mainly the breast, thyroid, and endometrial. If we see a scenario involvement of the breast, thyroid, endometrial, adenoma or carcinoma or benign lesion, you must suspect it is a Cowden syndrome. Cowden syndrome, which is autosomal dominant, it genetically it is inactive mutation of PTEN. PTEN, this is a suppressor gene. A lot of question asking about which tumor suppressor gene causing Cowden syndrome. It is PTEN. And also another question asking about the mode of inheritance of Cowden syndrome, which is autosomal dominant. And in the scenario, there are some pathology, breast pathology, thyroid pathology, and endometrial carcinoma. Thyroid features include a non-medullary thyroid carcinoma, mostly follicular thyroid carcinoma, non-medullary follicular or papillary thyroid carcinoma, but most of them are follicular thyroid carcinoma. Another thyroid involvement include multinodular goiter, thyroid adenoma, and rarely parathyroid adenoma. In exam, they favor syndromes, rarities, and also another clinical feature that increase the risk of malignancy lymphadenopathy, especially if there is a loss of the hilum. History of Hashimoto disease increase the risk of lymphoma, and of course TSH, elevated TSH, we must suspect it may be thyroid malignancy. Of course, the best modality for investigation in thyroid in each case of thyroid nodule is fine needle aspiration biopsy. In every case, the first test to order is TSH. If TSH is low, the next step is to do thyroid scan. If TSH is low, the next step is to do thyroid scan, thyroid radioactive iodine uptake. If it is elevated, so it is a toxic adenoma or toxic multinodular goiter. If it is normal TSH or TSH is elevated, the next best step is to do fine needle aspiration biopsy. Of course, fine needle aspiration biopsy according to ultrasonographic pattern of thyroid nodule. If it is a pure cystic, no role for fine needle aspiration biopsy. If U2, for example, no role for fine needle aspiration biopsy. But if U3 and more, we must do fine needle aspiration biopsy according to the nodule size. A respiratory flow loop, especially in large goiter, is mandatory to exclude compression, tracheal compression or obstruction. And of course, CT scan and MRI is very important in retrosternal goiter for exclusion of tracheal compression. A treatment
Dr. Khalid.
Yes, Dr. Pam.
And Dr. Khalid, first we will do USG and then radioiodine uptake.
Yes, yes, of course. This is the first. In every case of thyroid nodularity, we must do fine thyroid ultrasonography. This is the first one to do. And of course, TSH at the same time. Okay. After that, after risk stratification by ultrasonographic imaging, the next step, if TSH is low, then go to thyroid scan. If TSH is normal or high, the next step is to do fine needle aspiration biopsy according to the risk stratification which was done previously by ultrasonography. Of course, the management of toxic multinodular goiter or toxic nodule, the antithyroid drug, this is beneficial in controlling hyperthyroidism, but the definitive treatment of toxic multinodular goiter is radioactive iodine ablation or surgery. This is the best one. The antithyroid drug just a bridge to render our patient euthyroid. And of course, the carbimazole is the best modality for treatment. Propyl thyroxine has no role in any case, in any hyperthyroid case except first trimester and thyrotoxic storm, and in very limited case in during the pregnancy with not in the first trimester only. Radioiodine, of course, this is the first choice for definitive treatment of two cases actually. In a case of toxic adenoma or multinodular goiter, radioactive iodine is the first choice. And another choice is the first, radioactive iodine is the first choice in every case of a Graves relapse. A relapse of a Graves disease, radioactive iodine is the first choice, except if there is non-compliance or the patient preference not to prefer radioactive iodine or cannot apply the safety profile for radioactive iodine. Dr. Muhammad Khadir, I mute you. Oh. Of course, radioactive iodine in most cases induce euthyroid state, and in most cases after 4 to 6 weeks of radioactive iodine. And if you decide that your patient is still hyperthyroid, the next dose of radioactive iodine not less than 6 months. This is also a repeated question in the SE and European Board. The next dose of radioactive iodine, the second dose of radioactive iodine, not less than 6 months after the first dose. And of course, for male and female fertility, not less than 6 months from the radioactive iodine dose. Of course, the dose of radioactive iodine for toxic toxic nodule or multinodular toxic goiter is 500 to 800 megabecquerel, which if you want to convert it to millicurie, you divide it by 37. Of course, surgery for removal of toxic and all thyroid is another modality for treatment of toxic adenoma. A non-toxic multinodular goiter, of course, surgery is a preferred treatment in a patient with local compression or for cosmetic disfigurement. A solitary nodule with fine needle aspiration suspicious of malignancy, we can refer it for surgery to do lobectomy or total thyroidectomy according to the ultrasonographic risk stratification. A radioiodine ablation, this is not usually effective in non-toxic multinodular goiter, but at least it can reduce in nodular size by about 50%, but this needs a long period. This is not usually done in most cases, but in some cases we can use radioactive iodine in non-toxic multinodular goiter to reduce its size. But if it is a retrosternal compression or you need a rapid reduction in the goiter, this is not your choice. Hypothyroidism following the radioiodine is relatively low, but it is still recognized because most of iodine is concentrated in the toxic nodule. Medical treatment by levothyroxine as a suppressive therapy in euthyroid patient for management of the nodule is not recommended nowadays because it increases the risk of cardiac arrhythmia and bone loss because it induces iatrogenic thyrotoxicosis. So, medical treatment of non-toxic nodule, no medical treatment. Etiology of goiter, autoimmune thyroid disease, or sporadic or endemic, especially iodine deficiency or dietary origin in pregnancy will cause physiological goiter, and also a drug used like antithyroid drug or lithium or amiodarone can cause a goiter, and also most cases of thyroiditis can cause a goiter. Pathology is not important, but the thyroid nodule in pregnant woman increases the size during gestation, increasing the number, deal with it as a non-pregnant nodule. Any nodule during the pregnancy, deal with it as a non-pregnant. Do fine needle aspiration biopsy if indicated, and of course, if you need a surgery, postpone it to the second trimester or just postpartum. This is, and inshallah in the lecture presented by Dr. Ibrahim Al-Ali, he will discuss more details on the thyroid nodule and the thyroid malignancy. The next topic today, inshallah, thyroiditis. Thyroiditis, it means just inflammation of the thyroid gland, mostly maybe transient thyrotoxicosis. This is the first stage. Then followed by hypothyroidism or euthyroidism. Overt hypothyroidism caused by autoimmune, but you must know that autoimmune hypothyroidism means Hashimoto, which is presented by a goiter, and of course, the anti-TPO is positive in about 100%. And another autoimmune thyroid disease is atrophic thyroiditis. This is the end stage of Hashimoto thyroiditis. Someone said it is the end stage of Hashimoto thyroiditis. Hashimoto thyroiditis, atrophic thyroiditis, both of them, anti-TPO is positive, but in Hashimoto thyroiditis, there are a goiter. In atrophic thyroiditis, mostly there is no goiter. It is atrophic thyroiditis. The causes and characteristics of thyroiditis, this is just enumerated. الهاشيموتو thyroiditis, البوستبارتم
دكتور خالد
thyroiditis. Yes.
انتي تي بي او اللي هو الانتي تي اس اتش
No.
ولا الانتي ميكروسومال؟
الانتي مايكروزومال. الانتي تي بي او الفورمال نيم از الانتي تي بي او الفورمال نيم از انتي مايكروزومال انتي بودي. Nowadays it is anti TPO, anti thyroid peroxidase antibody. It is not pathognomonic for any disease. It may be present in normal population in about 7 to 30%. It is present in the postpartum thyroiditis in about 90 to 100%. It is present in Hashimoto in the same percent. Also, it may be present in a patient with a grave disease in about 80%. And also a relative of a patient with autoimmune thyroid disease may be present in about 40 or 50%. Also in type 1 diabetes may be present in about 40%. Also presented in a pregnant female in about 14%. So anti-TPO is not diagnostic for any, just a marker for autoimmune thyroid disorder. But the most important autoimmune thyroid lab is TRAB, which is TSH receptor antibody, which is pathognomonic for Graves' disease. As we said previous a lot of times, it TRAB positive, it means Graves' disease. If it is negative, it means exclude the Graves' disease in about 95% of the cases. So anti-TPO is positive. This is suggestive of autoimmune thyroid disease, which means Graves' disease, postpartum thyroiditis, Hashimoto thyroiditis, atrophic thyroiditis. A lot of disorders can cause anti-TPO is positive. No one, anti-TPO does not diagnose which one is the cause of thyroid problem. If TSH is low and anti-TPO is positive, this means maybe Graves' disease, maybe thyrotoxic stage of postpartum thyroiditis, maybe thyrotoxic stage of thyroiditis, actually not diagnostic for anything. Okay, Dr. Ahmed? So postpartum thyroiditis, characteristic lymphocytic thyroiditis or transient thyrotoxicosis, and may be presented by hypothyroidism in the late stage after 6 months postpartum. Also, drug induced, it may be amiodarone and interferon alpha may cause thyroiditis, and we will discuss it in more details after a few slides. Subacute dequervian thyroiditis, this is very important because it is diagnostic mainly by thyroid tenderness. Thyroid tenderness, ESR is elevated, and the patient laboratory function test shows thyrotoxicosis. You must suspect this is a dequervian thyroiditis or subacute. And of course, dequervian thyroiditis, it is treated by just non-steroidal anti-inflammatory drug and rarely needs corticosteroid. In a very limited cases, may be treated by corticosteroid, but no role for anti-thyroid drug for subacute dequervian or dequervian thyroiditis. Radial thyroiditis, this is very rare. It is extensive fibrosis. It is a thyroid gland hard. If you palpate a thyroid gland, just woody-like or hard, very hard tissue. This is a radial thyroiditis, and the radiation thyroiditis, this is a radiation injury, transient thyrotoxicosis, and then thyroiditis. And most of some of our patients who receive radioactive iodine, one of radioactive iodine side effects is radiation thyroiditis, just a pain and thyroiditis of the thyroid gland. Biogenic thyroiditis or biogenic infection, this is abscess, mostly caused by Staphylococcus aureus streptococci. This is an abscess in the thyroid gland and treated by drainage and antibiotic. A clinical presentation to differentiate between some types of thyroiditis, as we said, is suburative or acute thyroiditis. This is painful, tender thyroid and fever, and thyroid function test mostly will be normal. Subacute or dequervian, this is in a lot of questions they ask about subacute or dequervian thyroiditis because they give a scenario Thyrotoxicosis, TSH is low, T3, T4 is elevated, but they mentioned that there is a painful thyroid. May be preceded by upper respiratory tract infection and generalized malaise, and of course thyroid function test thyrotoxicosis. This is the Quervian thyroiditis and treated by just non-steroidal anti-inflammatory. And ESR is very important in this scenario because ESR is elevated, and of course the thyroid gland will show low uptake. And this also another very important, how to differentiate between of course the Graves' disease versus the Quervian thyroiditis. Graves' disease thyroid scan will be high, but in the Quervian thyroiditis thyroid scan will be low. And another differentiation, TRAb is positive in the Graves' disease, negative in the Quervian thyroiditis. Also painful thyroid in the Quervian thyroiditis, but not painful thyroid gland in the case of Graves' disease. Another one, which is autoimmune thyroid disorder, don't forget that both autoimmune Hashimoto thyroiditis and atrophic thyroiditis, both are autoimmune thyroid disease, both are anti-TPOs positive. Radels, which is hard wood consistent thyroid gland, and of course the thyroid function test will be normal.
Dr. Khalid,
yes,
just now you said that anti-TPO is usually not diagnostic of any thyroiditis, but when it comes to the Hashimoto's or atrophic, I mean, its activity is measured by the anti-TPO, isn't
yes,
it?
Yes, anti-TPO is positive in about 100% of cases of autoimmune thyroiditis, but also it is present in Graves' disease, also in the relatives of autoimmune thyroid disorder, also in the general population. So it is not like a TRAb, for example. If you see TRAb, Dr. Robin, it is a diagnostic for Graves' disease. But if you see anti-TPO, it is not diagnostic for any thyroid disease, but it is suggestive. It may be Hashimoto, it may be, yes, Dr. Khalid?
Yeah, I mean, in Hashimoto's, it has been mentioned that it's if 80 to 90% it will be positive. It's just a, I mean, it gives a clue towards the diagnosis, but that's
yes,
not the absolute.
Yes, it is just a marker for autoimmune thyroid disorder. But actually, for example, in radal thyroiditis, anti-TPO is not positive, but in the autoimmune thyroid disease, it is positive. In subacute Quervian thyroiditis, anti-TPO is not positive, and of course, TRAb is not positive in anyone. So it is just a marker of autoimmune thyroid disorder.
Okay.
But for example, anti-TPO is positive in about also 100% in the case of postpartum thyroiditis. In the case of postpartum thyroiditis, anti-TPO is positive. Excuse me, just I have a phone. Just a minute, please.
Okay.
Excuse me. Let's start by one of the most important issue in the hypothyroidism, which is a chronic autoimmune thyroiditis, which include atrophic and Hashimoto, as we mentioned previously. The main difference, Hashimoto presented by a goiter, which is irregular consistency and irregular surface, and of course may be presented by subclinical or overt hypothyroidism. TSH will be elevated, but if free T4 is normal, this is subclinical hypothyroidism. If free T4 is less than normal, it is overt hypothyroidism. And a very rare case of Hashimoto thyroiditis may be presented by thyrotoxicosis, ill stage, presented by thyrotoxicosis. As we know that most of thyroiditis, destructive thyroiditis, may be presented by leakage of thyroid hormone, so can cause thyrotoxicose, and manifestation of thyrotoxicose actually is mild and for short duration. And of course, anti-TPO, as we said, is positive. Atrophic thyroiditis, this is end-stage thyroid disease, and of course, the thyroid gland is not enlarged. The investigation of any case of Hashimoto thyroiditis, of course, the thyroid function test, TSH and FreeT4. No role for a T3 in hypothyroidism, no role for a T3 or a free T3 in any case of hypothyroidism. The thyroid autoantibody, anti-thyroglobulin antibody is positive in about 20% of cases, and of course, the anti-TPO is positive in more than 90%. We can do a thyroid biopsy, as we said previously, if we suspect only a case of thyroid nodule with a suspicious manifestation, or we suspect a lymphoma for diagnosis. The prognosis of Hashimoto thyroiditis of course, if there is a rapidly enlarging goiter, we must suspect it may be lymphoma, or maybe need a corticosteroid in a dose of 40 milligram daily may be beneficial in this scenario if there is a pain and rapidly enlarging goiter, but you must exclude a lymphoma. Any unusual increase in the size of thyroid in patients known to suffer from Hashimoto thyroiditis should be investigated with fine needle aspiration biopsy to exclude the risk of lymphoma, which risk increased by about 70 folds in a case of Hashimoto thyroiditis. Another causes, another types of thyroiditis, which is silent thyroiditis. This is thyroiditis with low uptake, or actually all thyroiditis, radioactive iodine uptake is low. Postpartum thyroiditis, this is very important, and I think in the previous session we discussed it in more details. Of course, this is diagnosed in the first 6 months or 1 year, actually in the first 1 year postpartum, and a thyrotoxic phase in the first 3 to 6 months, followed by a hypothyroid phase, and then euthyroid or persistent hypothyroidism. The prevalence of postpartum thyroiditis 5 to 7%, and this actually in a previous exam they asked about the prevalence of postpartum thyroiditis. And the postpartum thyroiditis develops in about 30 to 50% of the females who are positive, anti-TPO is positive. And of course, most of patients of postpartum thyroiditis return to the euthyroid, most of them actually. Radial thyroiditis, this is intense fibrosis of thyroid gland, maybe mediastinal or retroperitoneal fibrosis, maybe accompanied by mediastinal or retroperitoneal fibrosis, salivary gland fibrosis, or sclerosing cholangitis, or lacrimal gland fibrosis, and parathyroid gland fibrosis leading to hypoparathyroidism. And the patient usually euthyroid, and of course the management corticosteroid is not usually effective, but tamoxifen may be used. Tamoxifen, which increase the level of TPG, can be used in the management of chronic fibrosing thyroiditis. Pyogenic thyroiditis, this is acute abscess, tenderness and the swelling of the thyroid gland, redness and warmth, and of course the thyroid ultrasonography can be diagnostic because it can show the abscess, and also there are a constitutional signs of infection, and of course a treatment by antibiotic and incisional and the drainage for this abscess. Subacute thyroiditis, as we mentioned previously, this is viral in the origin, and of course the patient complain from the, especially in the preceding 2 weeks, asthenia, malaise, pain over the thyroid, pain referred to the lower jaw or ear or occiput, tenderness over the thyroid, ESR and C-reactive protein is elevated, and of course the thyroid scan will be low. The patient may be presented by thyrotoxic stage or hypothyroid stage, and of course the treatment just non-steroidal anti-inflammatory, and in the rare cases, severe cases, we can use corticosteroid in a dose of 20 to 40 milligram per day prednisolone, and of course the propranolol can be used if there is tachycardia or tachyarrhythmia. A treatment can be withdrawn when it's, once the free T4 is returned to normal, the treatment can be stopped. And of course, if the patient presented by hypothyroid, especially overt hypothyroidism, we can treat by a short period with levothyroxine for 3 months and so on. Of course, the carbimazole propyl uracil is not indicated in the Quervian thyroiditis. Drug-induced thyroiditis, this is very important, especially amiodarone and lithium. Amiodarone can cause hypothyroidism in about 13% of cases and can cause thyrotoxicosis in about 2%. And the lithium, in most cases of the lithium, which is used for treatment of bipolar disorder, can cause hypothyroidism, and in very rare cases can cause hyperthyroidism. Interferon alpha can cause thyroid dysfunction. Also, interleukin 2 can cause a thyroid dysfunction. Hypothyroidism, of course, hypothyroidism results from a variety of abnormalities to the thyroid gland, results in insufficient secretion of thyroid hormones, LF54, which is converted to T3. And of course, incidence higher in area of high iodine intake, because of course iodine can suppress, high intake of iodine can suppress the thyroid hormone synthesis and their release. Elevated TSH is associated with high serum lipid concentration. So in every case of hypothyroidism, there is a lipid abnormality. A clinical picture, as we know, this is just insidious, non-specific onset, fatigue, lethargy, constipation, cold intolerance, muscle stiffness. But don't forget that menorrhagia later and oligo or amenorrhea can be a presenting manifestation. And the most important one, the appetite is low and the patient may be presented by weight gain. And another one, skin is dry and hair loss. And we can diagnose it by from the phone by finding that there is a deep hoarse voice, and of course decrease in visual acuity and obstructive sleep apnea in some cases. Myxedema, this is a dull expressionless face, sparse hair. Myxedema, this is hypothyroidism. But pretibial myxedema, this is a pathognomic sign for Graves' disease. You must differentiate between post-10. Pretibial myxedema, this is a pathognomic feature for Graves' disease, but myxedema by name, it is a hypothyroidism. In the myxedema or hypothyroidism, the periorbital puffness, the macroglossi, don't forget that skin is pale and cool, that feels roughy and doughy. And of course, enlarged heart dilatation and maybe pericardial effusion. This is a very critical manifestation of non-organized myxedema. And of course, megacolon, intestinal obstruction, cerebral ataxia. Don't forget that deep tender reflexes will be prolonged, and in the prolonged relaxation phase of deep tender reflex. And of course, may be presented by peripheral neuropathy, encephalopathy, hyperlipidemia, hypercarotinemia, and some psychiatric manifestation like depression and psychosis and so on. And of course, hyponatremia is one of the electrolyte abnormality which you must search for in a case of hypothyroidism. Classification and cause of hypothyroidism, of course, non-goiter, no goiter in a post-ablative or either by radioiodine or surgery. In any case of Graves' disease, which do surgery or radioactive iodine, it is presented by hypothyroidism. Of course, TSH is elevated, 54 is low, but no goiter. Another one, a congenital development defect, congenital hypothyroidism, atrophic thyroiditis, which is autoimmune thyroiditis. Post-radiation will cause non-goitrous hypothyroidism. Goitrous hypothyroidism, like Hashimoto thyroiditis, in a case of the Quervian thyroiditis, in early stage of the Quervian thyroiditis, in any case of iodine deficiency, and of course, iodine deficiency is the most common cause of hypothyroidism worldwide is iodine deficiency. But in the Europe, in UK, Hashimoto thyroiditis is the most common cause of hypothyroidism worldwide, iodine deficiency. But in UK, Hashimoto thyroiditis. Another drugs that can cause goitrous hypothyroidism, amiodarone or iodide, lithium, rifampicin, sunitinib, and so on. Hemochromatosis is very rare. Maternal transmitted hereditary biospecific defects can cause hypothyroidism. Also, in the central hypothyroidism, which presented by low 54 and low normal TSH, low or low normal TSH, and in mild case, mild elevation of TSH, which is very difficult to diagnose, central hypothyroidism. And of course, in the case of panhypothyroidism or isolated TSH deficiency, or some drugs like bexarotene can cause central hypothyroidism. So in central hypothyroidism, the FRT4 is low, TSH may be low, may be normal, and may be mildly elevated. And this is very difficult to diagnose because it is conflicted with overt hypothyroidism. TSH is mildly elevated, FRT4 is low. This can be presenting thyroid laboratory function. In the case of central hypothyroidism, you can diagnose it by another anti-pituitary hormone deficiency or a history of hypothalamic or pituitary or CNS lesion. You must suspect in this scenario central hypothyroidism. Another one is hypothalamic lesion like neoplasia or infiltrative or infection can cause the same as pituitary. TSH will be low or mildly or low normal, and the FRT4 is low. Self-limiting cases, this is just, for example, postpartum thyroiditis or subacute thyroiditis, or following withdrawal of suppressive thyroid therapy, TSH will be elevated and the FRT4 is low. This is like overt hypothyroidism.
Dr. Khalid,
yes,
there is, goitrous hypothyroidism is more common in iodine deficient areas. Then
yes.
why it is written in epidemiology that incidence higher in areas of high iodine intake?
Yes, because high iodine intake, usually high iodine will suppress iodination senses and the release of thyroid hormone. So it will cause.
I mean, that means non-goitrous is more common than goitrous.
Actually, I don't know which is the commonest, non-goitrous or goitrous.
If the incidence is higher in high iodine intake, it will cause non-goitrous. That means it will be higher incidence.
I think high iodine intake, hypothyroidism in general. In this slide, they didn't specific. It is for which one? I think this one. No, page which one?
I'm reading it for 74. Page 74.
74.
Epidemiology.
Okay. Here in this one, this hypothyroidism.
After this.
After this.
Epidemiology of hypothyroidism.
Okay. This is one. Okay.
Yeah.
Incidence higher in area of iodine intake. They didn't mention is it a goitrous or non-goitrous. Here is he asked about
hypothyroidism. High iodine intake can cause goitrous also.
Yes.
No, usually the goiter is usually due to the iodine deficiency, isn't it?
Both of them. The most common cause of hypothyroidism in worldwide is iodine deficiency. But in area with high iodine intake, according to the decrease in senses and the release of thyroid hormone, this will cause hypothyroidism by another mechanism.
Okay.
But which is more common, I don't know actually. This or this. This is very important pitfalls with thyroid function test. Usually, the interpretation of thyroid function test is straightforward. TSH is low, FRT4, free thyroid hormone is elevated. This is thyrotoxicosis. And the opposite, TSH is high and free thyroid hormone is low. This is hypothyroidism. Subclinical, if TSH is elevated or low, but thyroid hormone is normal, this is subclinical. But in another circumstances, we see a conflicting thyroid laboratory testing. For example, TSH is high and the thyroid hormone is elevated also. This is give us some conflict, some challenge in diagnosis of thyroid disorder, and this is very important because it is not common, but we must diagnose it. This is the fantastic issue of the endocrine. TSH is suppressed, of course, in any hospitalized patient. In most of hospitalized patients, this is a case of non-thyroidal illness or sick sick euthyroid syndrome. TSH will be low, but actually the first parameter to be affected is T3. So this syndrome,
right?
yes, low T3 syndrome, which is sick and non-thyroidal illness. In this scenario, T3 will be low, and then T4 will be low, and the TSH may be low or low normal. Another very important issue that the steroid and the dopamine, both of them can
But
decrease
here reverse
the TSH.
T3 will be increased now.
What?
Reverse
in recovery
T3
state, recovery,
Yeah.
reverse T3, of course. Reverse T3 in most cases it is the opposite than T3. In sick euthyroid syndrome, the most important one is T3 is low, and the reverse T3 is elevated. And of course, this is very important to diagnose sick euthyroid syndrome, because in all exam they asked about this case scenario. In any case, in any patient admitted to the intensive care unit, don't do routinely thyroid function test except you have a high suspicion of thyroid disorder, you have a high suspicion of, for example, myxedema coma, you have a very high suspicion of thyroid storm. In this scenario only, you order thyroid function test. If you don't suspect these situations, don't order thyroid function test because it will mislead you. What? دكتورة نجلاء. Okay. Another very important issue that in steroid, the patient who receives steroid or dopamine, TSH will be low. Of course, suppression of TSH is just mild suppression of TSH. TSH will increase during recovery period after acute illness. This is the opposite than in non-thyroidal illness. In non-thyroidal illness, TSH will be suppressed or low. In the recovery state, it will be increased. And of course, TSH may be followed during the first trimester, as we know, by beta HCG, and this is a very important issue because the trimester specific reference range is different from TSH is different from pregnant and non-pregnant females. TSH inhibited by subcutaneous octreotide, like the same as the dopamine and the steroid. These three drugs can cause a TSH low. And also in anorexia nervosa, it can cause a TSH low, and also LF84 will be low. Another one which is important, heterophile antibody. Heterophile antibody will cause a TSH mild elevation of TSH, mild elevation of TSH, and also can cause mild elevation of LF84. But actually, LF83 will be normal in the heterophile antibody. And also the heterophile antibody is not affect thyroid by name, thyroid testing. Also it may affect another laboratory testing. Adrenal insufficiency may be associated with raised TSH. And in this scenario, before you manage a case of overt hypothyroidism, you must exclude the adrenal insufficiency. Because if you treat this patient with levothyroxine without a cover with corticosteroid, the patient may be complaining from adrenal crisis.
Adrenal crisis.
Yes, and this actually we discuss it in more details in the guidelines of hypothyroidism, hypopituitarism, and previous in the pituitary chapter. And this is very important. In adrenal insufficiency, you may suspect mild rise of TSH. Once you treat adrenal insufficiency, TSH will be normalized. Don't try to treat hypothyroidism before you treat adrenal insufficiency because it is fatal. A subclinical hypothyroidism, this is a very important topic. Of course, as we know all, any subclinical means the thyroid hormone is normal with the TSH is elevated in hypothyroidism, suppressed in or low in hyperthyroidism. A treatment is indicated not in all cases, but in some limited cases. When to treat subclinical hypothyroidism, this is very important because there are a lot of controversy about it. At least if there is a history of radioiodine treatment for thyrotoxicosis or positive anti-TPO or symptoms or infertility or during the pregnancy, you can treat. But you should know that 2 samples should be taken 2 to 3 months apart to distinguish from non-thyroidal illness. But this is not practically during the pregnancy or fertility. If you suspect a pregnant female present to you with subclinical hypothyroidism, you must treat it. And of course, the reference range for serum TSH rise with age. For elderly people, TSH reference range is more than a young adults. There is a controversy over the advantage of levothyroxine in patients with a negative anti-TPO and no previous radioiodine treatment. Of course, if a treatment is not given, just follow your patient annual by thyroid function test. If you discover a case of subclinical hypothyroidism and you decide that no need for a treatment, you just do TSH every 1 year. There is no general acceptance consensus of when patients should receive a treatment. Some authorities suggest a treatment if a TSH is more than 10. Most authorities suggest to treat this patient except the elderly one. And we will discuss it in more details according to the guidelines published by the ETA. And of course, increase the incidence of cardiovascular risk probably greater if less than 65 years, you can treat. But if the patient age is more than 65 or 70 in the latest guideline, no need for treatment in a subclinical hypothyroidism except if the patient is symptomatic. If it TSH, for example, 20 and the patient age is 70 years old, no need for treatment except if symptoms. In a case of recurrent miscarriage, you can treat subclinical hypothyroidism to bring TSH to less than 2.5. Of course, during the pregnancy, you must treat, especially if the anti-TPO is positive. This is a a recommended recommendation by most of guidelines. During the pregnancy, if the anti-TPO is positive, you must treat subclinical hypothyroidism. And of course, the reference range, our target TSH, the lower half of the reference range prior to conception is about 0.1 for in the first trimester to 2.5 in the first trimester and so on. The management, if it TSH is more than 10, treat. If it TSH between 4 and 10 and anti-TPO is positive, treat. If the anti-TPO is negative, just follow up by TSH every 3 to 5 years. This is very important, but actually is not practical. And in a case of subclinical hypothyroidism, he mentioned that the anti-TPO is positive and subclinical hypothyroidism, just to do TSH every 3 to 5 years. I think this is not practical in our practice. Most of us repeated TSH after 3 to 6 months, not 3 to 5 years actually. If the patient with serum TSH 4 to 10 and has symptoms consistent with the hypothyroidism, you can try to treat by levothyroxine for 3 to 6 months as a therapeutic trial. Because most of hypothyroid manifestation or symptoms is not highly specific for hypothyroidism. If it TSH is from 4 to 10 subclinical and does not have symptoms and the serum TSH level appears stable with the positive anti-TPO, just annual risk of progression to overt hypothyroidism is 4% per year, just to do annual TSH. TPO negative, then every 3 years to do TSH, and as we said, it is not a practice. And of course, in the neonate and children, pregnancy, and some ones trying to conceive, you should treat subclinical hypothyroidism. And of course, some of data in a patient with a TSH from 5 to 10, and the age is less than 65, but you can treat, but if there is a heart failure on echocardiography, but try to treat with a small dose of levothyroxine. And this algorithm published by ETA guidelines in 2013, they mentioned that there is no anti-TPO rule for management of subclinical hypothyroidism. Here he mentioned just if the age is less than 70, in the previous guideline 65. If his serum is more than 10, then treat. If TSH is less than 10, if there is a hypothyroid manifestation, then a trial for a treatment. If no manifestation, just observe and repeat after 6 months. This is for young, not pregnant, not infertility. But if the age is more than 70 years, serum TSH is more than 10, treat if clear symptoms of hypothyroidism. If less than 10, just observe and repeat thyroid function test after 6 months. This is very important because actually in the European board examination or SEC examination, ask a scenario like this. Give you a patient with age, for example, 80 years old, and the TSH is more than 10 and no manifestation of hypothyroidism, to treat or not to treat, just observe or and to follow up when and so on. This is some slides from previous lectures. The main goal of treatment of hypothyroidism to symptom resolution, normalization of TSH, and avoid over-treatment. And of course, the main line of treatment by levothyroxine, no role for triiodothyronine, no role for T3 replacement therapy. How to determine dose in the management of hypothyroidism? Mainly by a lot of factors. The most important one is the weight of your patient. The weight of your patient is the main factor that determines the dose of levothyroxine. Another one is pregnant or not. Another one, what is the etiology of hypothyroidism? It is subclinical, and the last one is TSH elevation, subclinical or not hypothyroidism. And another factor that must be put in your mind before treatment of any case of hypothyroidism, the patient's age, because in the elderly, in any patient age more than 65, you must start by low dose of levothyroxine. Don't try to replace by a full dosage of thyroxine. But in the young patient, you can correct by full dosage of levothyroxine. Also, the comorbidities can affect your starting dose, because in ischemic heart disease, you must try to start by a very small dose and upward titration in every 2 weeks. And also, our target of TSH must be determined, because usually a target of TSH is the lower half of the normal, from 0.5 to 2.5 in most our cases. But with differentiated thyroid carcinoma, this target is different, because according to our risk classification for our patient, the target of TSH is different. And of course, in most of cases, we can replace by full replacement dose or partial replacement dose, and to do and follow up every 4 to 6 weeks after changing of the dose until stabilization of TSH, and then every 6 months, and then annually to follow up. The average replacement dose, this is very important practically, is 1.6 to 1.8 microgram per kilogram per day. For example, if we have a patient, his weight is 100 kilogram, the full replacement dose is about 160 microgram levothyroxine per day. This is very important practically. Just the patient's weight multiplied by 1.6 to 1.8. This is the full replacement dose. And of course, you can titrate this dose according to the TSH after 4 to 6 months of your dose. Of course, our TSH target is 0.5 or 4 to 2.5 or lower half. When you give levothyroxine, this is very important. Of course, levothyroxine must be given in empty stomach, because the absorption of levothyroxine is affected by a lot of factors: the iron therapy, the aluminum hydroxide, the proton pump inhibitor, the sacral fate, the calcium carbonate, and so on. So it must be given 16 60 minutes before breakfast or at bedtime, but 3 or more hours after the evening meal. This is actually is not practical in our societies to give levothyroxine at bedtime, but it is very important practically to give it once the patient woke up to take his drug and at least 60 minutes before his breakfast. This is very important because compliance and when we deal with the thyroid function test, the compliance is very important, and when the patient take his drug and another one. Also, a lot of drugs, a lot of factors can interfere with the levothyroxine absorption, like the calcium carbonate, the ferrous sulfate, aluminum hydroxide, the sacralfate, and even the proton pump inhibitor can affect the absorption because the levothyroxine is absorbed well in acidic media. If you give your patient H2 blocker or proton pump inhibitor, it will be decrease the stomach acidity, and this will affect the absorption of levothyroxine. And of course, in the second hypothyroidism, we follow up our patient by L-free-T4, not TSH. And of course, this is very important. Practically, in any case of cardiac disease, especially ischemic heart disease, we must start by very low dose of levothyroxine by 25 to 50 microgram daily, and increase the dose for every 2 to 4 weeks interval, not more, not less. And of course, in the elderly, it means the patient over 65 years, we must start by a very low levothyroxine, and of course increase the dose as the cardiac patient. In a patient, older patient, more than 70 years old, of course TSH reference range may be more than young adults. And of course, the replacement dose in the neonates, it is more than in the adults. We said that the replacement dose is 1.6, but in the neonate, the replacement dose weight multiplied by 10 to 15 microgram per kilogram per day. For example, if we have a baby who born, his weight is 4 kilogram multiplied by 15, you must suspect that the initial starting dose of levothyroxine for this new baby will be 50 microgram tablet daily. This is the same for young adult, young children. His weight is 10 kilogram, and with advancing age, this replacement dose will be less than this until in adulthood it reaches 1.6. During the pregnancy, this is very important because during the pregnancy, once in any patient, in any pregnant patient presented to you with hypothyroidism and in a stable dose of replacement therapy, you must increase the dose of thyroxine by about 25 to 50% once you hear it is pregnant. Actually, we must increase the dose by 25 to 50 microgram daily, and another one said that you must increase the dose by 2 extra doses per week. For example, if we have a female stable and controlled pre-pregnant in a 100 one tablet 100 microgram thyroxine daily, and the TSH is well controlled. Once she gets pregnant, you must increase 2 tablets, extra 2 tablets per week. So you must suspect that in some 2 days per week, she must take 2 tablets of levothyroxine 100 micrograms. This is just from previous lecture, and we will cover Oxford Handbook. Yes? Yes, Dr. Noor Ahmed?
Please, this increase of the dose for the pregnant, is it regardless of the TSH?
Yes,
like
actually,
if the TSH is 0.5.
Yes, actually, during the pregnancy, especially in the first trimester, التارجت TSH is less than non-pregnant. For example, for non-pregnant, the target TSH is about 0.5, but during the first trimester, our target 0.1. So actually, due to a lot of factors, this is another presentation. Actually, I speak about it. A lot of factors will affect daily requirement of levothyroxine. For example, the iodine requirement during pregnancy is increased from 150 microgram iodine intake for non-pregnant adults to be about 200 microgram international unit daily. And this increase of the iodine require more thyroxine, and also TPG will increase, which lead to the increased affinity to total thyroid hormone, and so on. Actually, a lot of factors will lead to increased dosage of levothyroxine in a stable new pregnant female.
Okay, thank you.
And of course, after that, you must guide it by TSH level. This is the from Oxford Handbook, how to treat hypothyroidism. The same, actually. Levothyroxine is the main line of treatment. Of course, the half-life of levothyroxine about 6 days, so you can combine 2 days dosage of levothyroxine. If any patient missed his ordinary dose of levothyroxine, he can take it in the next morning double, as a double. And of course, the full replacement dose is 106 to 108. And of course, we must take it in a fasting state, morning or evening, but you must know the last meal. In any patient with ischemic or cardiac or elderly, we must treat by a small dose of levothyroxine and increase by about 25 microgram every 4 weeks or 2 to 4 weeks. The optimal dosage criteria, serum restoration of the TSH is very important. And of course, to follow up every 4 to 6 weeks. And then once stabilization of TSH, we can just do annual monitoring by TSH. But of course, if the patient weight is increased or decreased, you must check TSH. If there is a pregnancy, you must check TSH. If there is a change in his form, for example, in Egypt, we have two forms, generic forms of levothyroxine. We have Eltroxine by Aspen, and another one by Merck, Euthyrox. If the patient already on brand name for some company, and this drug is not available, and he take another one from another company, he must do another TSH after changing his form by 4 to 6 weeks. Muscle problem may take up 6 months to full recovery, not rapidly restored, and of course, 5% of hypothyroid patient means symptomatic in spite of normalization of TSH. And this is very difficult issue to how to treat and how to deal with this patient. And some surgeons in this scenario advise to do total thyroidectomy in a case of hypothyroidism and still complaining after normalization of TSH. But this is not a randomized control trial, and this is not recommended by any thyroid authorities. And of course, the possible cause for this include the awareness of chronic disease, may be associated another autoimmune disease, or thyroid autoimmunity per se may cause a manifestation which is not known till now. How does it? A patient with heterogenic hyperthyroidism, serum TSH is low or suppressed. Of course, the risk of arrhythmia and the osteoporosis will be increased. The combination of levothyroxine with the T3 does not recommended because it has no benefits. And of course, in secondary hypothyroidism, we must follow by 3 to 4. And of course, during the pregnancy, as we said, we must increase the dose by 25 to 50%. And actually, in our previous SC exam, not the last one, the previous one, they give us a scenario that a female which is stable in 100 microgram levothyroxine and get pregnant. and his TSH is within normal, about 2.5, as I said. How to deal with? They give us four options or 5 options. One of them to leave the dose as it is, another one to increase the dose by 125, and another one to increase the dose by 150 micrograms.
Oh.
And actually, this question is very difficult because here they recommend to increase the dose by 25 to 50%. So increase the dose to 125 or 150. This is very difficult. And actually, I returned to some other books, and they said to increase the dose to 150. And inshallah, I think this scenario will be given in the next slides. It is now recommended to routinely increase the levothyroxine dose by 25 microgram daily in any female or replacement therapy when she learns she is pregnant. Once missed period and pregnancy test is positive, you must increase the dose by 25 microgram daily, which represents about 25 to 50%. This table is not very important. Actually, is management of yes.
It is for the UK doctors, I think, Dr. Khalid.
Yes.
For the different companies.
This is yes. I think this is just components of each tablet of levothyroxine presented in the UK. This is actually is not important, and actually this is contains a lot of excipient. I think this is very important in a patient who is allergic to some excipient to choose which one is. But actually, in the exam, this is not very important.
Okay.
Dr. Khalid.
Yes.
Dr. Khalid.
Yes.
Ultimately, in the body, T4 is converted into the T3. Even we take the levothyroxine, that is converted to T3. Then why do we not take T3? Why do we take? Why do we take T4?
Yes, this is a repeated question, actually, Dr. Ruben, because a lot of things. The first and most important one, the half-life of levothyroxine is prolonged. So it is ideal to us to take levothyroxine once daily dose, and even we can skip one dose and to give this dose in the next day. But with the T3, it has a short half-life, and we must take it a lot of times daily. The next very important one, there is no extra benefit if we take triiodothyronine T3 over T4. In every case, in every trial which compare levothyroxine alone or T3 alone or combination with T4 and T3 in the management of hypothyroidism, the best one is levothyroxine only, and no extra benefit if we combine with T3, even if the patient is still symptomatic. In a patient, if it's still symptomatic, some recommend combination with T3, but in our practice and in the latest recommendation, this is not recommended except in very limited cases, especially in research purpose only.
Excuse me, Dr. Khalid.
And actually, Dr. Ruben, and actually another one, of course, if we take levothyroxine T4, it is converted to T3. The body will take what he needs from conversion of T4 to T3 by the iodinase enzyme species type 1. Yes?
Okay.
So my question regarding some patients with the hypothyroidism that are still symptomatic despite T4. Is there a role for measuring T3?
No.
Some would say that a low T3, despite a normal T4 and a normal TSH, might indicate some iodinase enzyme defect, which might explain that these may be still symptomatic, and there might be a role for giving a combination of T4 and T3. What is your take on this subject?
Actually, the iodinase enzyme assay is not available in our country, so I don't have actually experience in it, but I think if anyone in Egypt, there is a Cyro-Alex conference, inshallah, after 1 month, and Dr. Tamir Shirpini will present the case presentation, as you said, a patient with hypothyroidism with normalization of TSH and still complaining. Inshallah, after this conference, I can give a hint about how to manage this case scenario according to the presentation presented by Dr. Tamir Shirbini, inshallah. If anyone from Egypt, it is a very fantastic conference. It is biannual conference presented by endocrine unit in Alexandria University. The head of it is Dr. Alia Al-Ajhouri, and of course the conference, secretary conference of the Alexandria Thyroid Association, and the conference is Dr. Tamir Shirbini, inshallah.
Okay.
How to manage myxedema coma? It is just we must identify and treat the precipitating factor, antibiotic therapy after blood culture, and of course we must manage hypothermia gently by passive external warming, and of course the humidified oxygen, and the slow rise in the core temperature by 0.5 Celsius per hour, and of course we must monitor cardiac and correct the hyponatremia. As we said, the hyponatremia is presented with hypothyroidism. And of course, monitor rectal temperature, oxygen, blood pressure, CVP, and the urine output. And of course, take sample for TSH and cortisol before starting the treatment. If hypocortisolemia, administer glucocorticoid. Thyroid hormone replacement mainly by levothyroxine T4. This is the dose, 300 to 500 microgram intravenous. If not available, we can give it by nasogastric tube as a starting dose, followed by 50 to 100 microgram daily until oral medication can be taken. If no improvement within 1 to 2 days, we can combine with triiodothyronine. This is not available actually in most of countries, and also give hydrocortisone 50 to 100 milligram every 6 to 8 hours in a case of cortisol deficiency. But after we treat, still elevated TSH in spite of treatment. Yes?
Dr. Khalid, may I just know, during the administration of T4, the IV administration, so will it be an IV bolus, or it should be over a couple of minutes, like 15 minutes, 10 minutes?
Actually, levothyroxine in our country is not available except in oral form. Actually, this is not. I don't practice this issue, so I don't know actually. But in the nasogastric tube, is just crush the tablets and give it in nasogastric tube as an oral form. But as intravenous, because this drug is not available in our localities, I don't know. Is it given intravenous infusion or a bolus form? Actually, I don't know. I can try to find it and tell you, or anyone if has data about this. And if anyone has a British national formula, can try to find it from this book or from the internet and let us know.
Okay, sure. Thank you.
We still elevated TSH in spite of our treatment by a full replacement dose, which is weight-based dose. Think about compliance. The most important issue in any patient who receive a large dose of levothyroxine and still TSH is elevated, compliance is number 1, and number 2, and number 10. After that, we must suspect malabsorption and so on. Compliance is very important. Management of persistently elevated TSH despite thyroxine replacement, lack of compliance, this is the first one. If TSH is still elevated when levothyroxine dose at 1.6 microgram per kilogram per day or higher, think about compliance. The next one, think malabsorption. Consider other drugs that may interfere with the levothyroxine absorption. As we said previously, a lot of drugs that can affect levothyroxine absorption, iron therapy, calcium, this is very important, sacral fate, proton pump, H2 blocker, can affect the absorption, and also another drugs that increase the clearance of thyroxine and lead to TSH is elevated, rifampicin, every drug that can affect cytochrome B 45 40 450 450 rifampicin, phenytoin, phenobarbital, carbamazepine, and also another drugs that decrease the absorption of thyroxine like calcium, ferrous iron, aluminum hydroxide, cholestyramine, omeprazole, sacralfate. If the patient is already on rifampicin or phenytoin, we suspect that his stable dose of levothyroxine must be increased. And also, if he receives calcium or ferrous sulfate, he must take levothyroxine, and after at least 4 hours, he can take his ordinary calcium or ferrous sulfate. And also, in a case of atrophic gastritis caused by Helicobacter pylori, this can decrease the absorption of levothyroxine by 30%. And also, a celiac disease can cause, can affect the levothyroxine absorption. If we see a patient and check the compliance, and of course, if lack of compliance, the most important one is to encourage compliance and check TSH after 3 months. If still compliance is assured, this is have 2 options: malabsorption, we can check celiac disease, or we must consider a thyroxine malabsorption. Thyroxine malabsorption, this is very rare. This is very rare, and can, if you suspect thyroxine malabsorption, you can consider this test, thyroxine absorption test. Actually, this test, the basis from this test, thyroxine, the half-life of thyroxine about 6 days. We give a supervised weekly dose of levothyroxine in your clinic. The patient, we must multiply 10.6 microgram levothyroxine. This is the daily dose, multiply by kilogram, multiply by 7 days. This is the week's day. And we give this dose as a single weekly dose for our patient. And after that, we must do TSH after 1 month. If TSH is not normalized, this is a thyroxine malabsorption. If normalized, this is a non-compliance. The patient does not receive his treatment as prescribed. This is very important, and in most cases is not needed. Actually, if you try to search, you will suspect a non-compliance, the first one.
Then what to do in case TSH doesn't normalize, in case like if we do this weekly single dose? Even if TSH is not normalizing.
I think in this scenario, I think maybe another T3, for example, may be used, increase the dosage of levothyroxine. And I think in this scenario, if you increase the dose, I think the absorption will be more and more. But don't try to increase the dose before diagnosis of thyroxine malabsorption, actually.
Okay.
Another not very important, but a practically important, congenital hypothyroidism. This is a common disorder. Incidence from 1 in every 3,015 neonates. All neonates should be screened routinely. In most countries, there are screening for neonates, and of course, most. Sorry, I think there is an internet problem. Is my screen okay or not yet? Okay.
Yes, now okay.
Congenital hypothyroidism, about 85% of the cases are due to the sporadic development defect in the thyroid gland, is thyroid dysgenesis. Of course, in some cases, there is a complete absence of thyroid tissue, which is a thyroiditis. The remaining 15% have thyroid dysharmoniogenesis defect. Thyroid gland is well developed, but the hormone synthesis defects. This is autosomal recessive. This is actually not very important, but the most important is Pendred syndrome. Pendred syndrome, it is overt or subclinical hypothyroidism with goiter with sensorineural hearing impairment. and this is due to the partial iodide organification defect detected by, this is not very important, and it is just replacement of hypothyroidism as we know, but we must know that daily requirement of thyroxine is about 10 to 15 microgram per kilogram per day. A clinical feature of congenital hypothyroidism, the neonates presented by prolonged physiological jaundice may be presented by goiter, hoarse cry. This is a late manifestation, feeding problem, constipation, and of course may be presented later by short stature and developmental delay, protruding tongue, and may be presented by umbilical hernia and retarded bone age and delayed dentation. In laboratory, of course, TSH will be elevated. This is in a primary thyroid disorder, but in central hypothyroidism, the 54 will be low. Of course, thyroid ultrasonography is important to detect the thyroid or absence of thyroid, and of course, the thyroid scintigraphy may be used to detect the uptake in the thyroid and which defects in the thyroid hormonogenesis. Serum thyroglobulin is elevated in all of thyroid disorders, but it is absent in absence of thyroid. And of course, the measurement of neonatal and maternal autoantibody here, TRAB, in a case of possible transient hypothyroidism, through passing of TRAB inhibitory antibody through the placenta if the mother diagnosed as a grave disease or previously treated by radioactive iodine, antibody still as it is and can cause a transient hypothyroidism for the baby. And of course, early treatment is beneficial, especially in the neurocognitive functions. And of course, sufficient T4 should be given to maintain the TSH in the normal range. And this is oral form and not syrup. It is just oral tablet, which is crushed in a small amount of water or even milk, and to be given to the unit. And of course, in this case, we cannot ask the mother to give her baby the drug in a fasting state. We can give it and she can lactate it, but actually we try to do this in the same manner every day. This is now we end our most of our presentation today, and we will go to the Amiodarone. If anyone has any question about the previous one. Okay, Amiodarone, in the first of the Amiodarone, I will give this lecture which I present in the second cardiodiabetes secrets in the previous month. This is just new information about Amiodarone. In 1961, a Belgium company developed a new drug to treat angina, and quickly becomes this drug popular anti-anginal drug in the Europe and South America. And later on, this Rosenbaum, this is an Argentinian physician, discovered this in every patient who treated by this new drug. This drug reduces cardiac arrhythmia. So discovered that this drug is anti-arrhythmic. At 17th, American began to obtain this new drug from the Canada and Europe to use it as a broad spectrum anti-arrhythmic. They tried to call a new name for this unique anti-arrhythmic drug, and they called it Amiodarone. Amiodarone, which means this drug almost always worked and had virtually no side effects. This is just an introduction for Amiodarone. They said this drug is very effective, and actually they think that there is no side effect of Amiodarone. But nowadays, a lot of side effects by Amiodarone affects actually all organs in the body, affecting nose, affect even the heart, can cause bradycardia or heart block or dysarrhythmia, and may cause prolonged QT, and also can cause nausea and vomiting and taste disorders. Of course, 100% of our patients complaining from corneal microdeposits from cordarone or Amiodarone, or so lung can be affected, or so liver can cause hepatitis. Even testes can be affected by Amiodarone, but the most important one is thyroid gland. In about 14 to 18% presented by thyroid dysfunction, even hypothyroidism or hyperthyroidism. A daily requirement of iodine in adults about 150 microgram per day, and during pregnancy is 200 microgram per day. One tablet of amiodarone, which contains 200 milligram of amiodarone, contains benzofuranic iodine rich, 37% of its weight contains iodine. So in every tablet of iodine of cordarone or amiodarone, it contains about 70 milligram of iodine. 70 milligram. The daily requirement is 150 microgram, not milligram. How does amiodarone affect the thyroid gland? The first initial step for amiodarone to affect the thyroid function, inhibit the deadenase enzyme, which is responsible for conversion of T4 to T3. So the first step is to decrease T3. T3 will be decreased after initiation of amiodarone by about 20% from the baseline. After that, low T3 will give a negative feedback to the pituitary and the hypothalamus, which lead to increase TSH by about 20 to 50% transient increase of TSH. And at the same time, due to the inhibited conversion of T4 to T3, T4 will be increased by about 50%. The net results initially change within 3 months of initiation of amiodarone. TSH will be elevated by about 20 to 50% from the baseline. T4 will be increased by 50%. T3 will be decreased by 15 to 20% from the baseline. This is the initial exchange. After that, after 3 months of intake of amiodarone, the negative feedback mechanism will be corrected. TSH, which elevated, will stimulate the thyroid gland to secrete more T3 and T4, but still T3 will still low, but T4 will be increased by 20 to 40% of the baseline, and this will normalize the negative feedback mechanism and returns the TSH to normal. So the net result after 3 months of amiodarone intake, TSH will be normal, T4 will be mildly increased, and the T3 will be low. So the most important one, after 6 months of amiodarone administration, TSH must be normalized. If TSH is elevated, this is amiodarone-induced hypothyroidism. If TSH is low, this is amiodarone-induced thyrotoxicosis. So if in any patient who receive amiodarone, we must do at the baseline TSH, T3, and T4. After 3 months, we must do this lab, and after then, every 6 months, we must do TSH. This is very important. After 6 months, in any patient receive amiodarone or lithium, we must do TSH. Of course, TSH is the most important test to follow up in any patient who receive amiodarone. According to the guidelines, in any patient receive amiodarone, if TSH is elevated, this is amiodarone-induced hypothyroidism, and it affects about 13% of patients who receive amiodarone. 13%, about 13 to 18%. The most debatable point to treat or not to treat, just observation. If the patient diagnosed as amiodarone-induced hypothyroidism, to treat or just to observe. This is very important. According to the guidelines published by the ETA in the management of amiodarone-associated thyroid dysfunction, the best, you must classify your patient. Is it a chronic autoimmune thyroiditis underlying thyroid pathology, chronic autoimmune thyroiditis, or normal thyroid gland? This can be done by 2 options, by thyroid ultrasonography. For example, this one is a picture of Hashimoto thyroiditis. This is a normal one. If the patient is a chronic autoimmune thyroiditis, by thyroid sonography, or if you do thyroid autoantibody, which is TSH-RAB antibody, which diagnose Graves' disease, or another autoimmune antibody, anti-TB or anti-TG, which is less specific. According to these results, if you diagnose underlying chronic autoimmune thyroiditis, we must treat by levothyroxine. If normal thyroid gland with normal thyroid autoantibody, the first one, can amiodarone be stopped or not? don't try to stop amiodarone without consultation with cardiologist. Try to consult a treating physician, a treating cardiologist before you stop amiodarone. Don't stop amiodarone by yourself in any case who receive amiodarone. No sound, Dr. Muhammad Hamada. Is my sound clear or not?
Yes, Dr. Khalid, it's clear.
Dr. Muhammad Hamada, clear? Dr. Muhammad Hamada, is it clear?
Yes, doctor, it is clear.
Okay, okay. Can amiodarone be stopped after consultation of cardiologist? No, then we can treat, especially if free T4 is low over hypothyroidism, especially if TSH is more than 20. If TSH is more than 20 or over hypothyroidism, free T4 is low, you must treat your patient. If amiodarone can be stopped, then stop amiodarone and reassess your case after 1 to 2 months. If it's still hypothyroid, then we must treat by levothyroxine. If normalized, then just to do follow-up. This is a very important algorithm how to manage amiodarone-induced hypothyroidism, and this actually from the ETA guidelines, but with my animation and my modification. Dr. Muhammad Hamad Hassan. Okay. How to follow patient to receive amiodarone? The next one, if TSH is low. This is a challenging dilemma actually, but we must know that T3 and T4 is normal, so this is a subclinical hyperthyroidism, just frequent observation. In subclinical hyperthyroidism, in a patient receive amiodarone, no need for treatment except in a very limited scenario. In a patient is elderly, in a cardiac patient, ischemic heart disease, osteoporosis, and so on, as we mentioned previously in the treatment of subclinical hyperthyroidism. If a T3 and the T4 is elevated, so this is amiodarone-induced thyrotoxicosis. T3 and the T4 is elevated and the TSH is low. This is amiodarone-induced thyrotoxicosis. And this is, of course, the manifestation of thyrotoxicosis, tachycardia with loss, tremor, diarrhea, and so on. This is not very important, but the etiology of thyrotoxicosis, as recommended by the guidelines published by the ETA, they recommend to do TRAB, TSH receptor antibody, radioactive iodine uptake, or thyroid blood flow on ultrasonography. And these three modalities for detection of the etiology of thyrotoxicosis is very important because a treatment is different. And of course, this is, as we mentioned, the previous thyroid autoantibody, which is a marker of autoimmune thyroid disease. It is a TRAB and the TPO may present in about 25% of in general population, and a relative population, half of relative population may be presented by anti-TPO positive. Even with a type 1 diabetes, maybe have TPO positive in 40%. Thyroid imaging is very important and very essential in determining the etiology of amiodarone-induced thyrotoxicosis, and the most important one is color flow Doppler sonography, CFDS. This is the one of the most parameters to differentiate between type 1 and type 2 amiodarone-induced thyrotoxicosis. Here, they mentioned that the peak systolic velocity, if it is elevated, it is with type 1. If it is low or normal, it is with type 2. This is not our duty, but we must ask the radiologist to do color sonography and detect the peak systolic velocity of inferior thyroid artery, which is normal or elevated. And the next one is thyroid scan, which is very important to differentiate between type 1 and type 2. And actually, in type 2, radioactive iodine will be very low. In most cases, will be near 0%. But in type 1 amiodarone-induced thyrotoxicosis, it may be low, may be normal, and may be elevated in some cases. Diagnostic evaluation of amiodarone-induced cytotoxicosis, it is prevalence presented in about 2% of cases who receive amiodarone. And the most important one is it treated by antithyroid drug in type 1 and treated by corticosteroid in type 2 amiodarone-induced cytotoxicosis. So the differentiation is it type 1 and treated by antithyroid drug, or type 2 which need corticosteroid as a treatment. This is our challenging concept. Amiodarone-induced cytotoxicosis, there are two types. Type 1, which is iodine-induced hyperthyroidism. This is a true hyperthyroidism, actually. This is type 1, this is a true hyperthyroidism, so treated by antithyroid drug. But in type 2, this is a destructive thyroiditis, this is a thyroiditis, and this is treated by corticosteroid, not antithyroid drug. And another one mixed type, which is a combination between type 1 and type 2. We can differentiate between type 1 and type 2 in our patient. So it is a mixed type, and we can treat it by combination of antithyroid drug with corticosteroid and withdraw some of them. How to differentiate between type 1 and type 2? And this is very important actually in exam. In type 1, there is underlying thyroid abnormality from ultrasonography, from antibody, from another modalities like this. Coronary flow Doppler sonography increased vascularity in type 1, but absent hypervascularity in type 2 like this. Thyroid radioactive iodine is low, normal, or increased in type 1, but in type 2, it is very low or suppressed or even 0%. This is very important. The thyroid antibody usually positive, especially trapping in underlying grave disease in type 1, usually negative, but may be presented in type 2 as a general population. Thanks, Dr. Iman. The onset time after starting a drug, of course, for amiodarone-induced type 1, short, median is 3 months, but in type 2, long, median 13 months. Spontaneous remission, actually in type 1, no spontaneous remission. So we must treat it by antithyroid drug and definitive therapy by serial radioactive iodine. But in type 2, maybe spontaneous remission occur in most cases. Once you treat by corticosteroid for a short period, the patient enters in the remission and resolve it, and just to do follow-up. Subsequent hypothyroidism type 1, no, but in type 2 may be possible subsequent hypothyroidism. And of course, coronary flow Doppler sonography and thyroid radioactive iodine uptake, this is the two modalities is the most useful modalities to differentiate between type 1 and type 2. So in any exam, in any question asked about which to do, coronary flow Doppler sonography, thyroidal radioactive iodine uptake, this is the most important two modalities to differentiate between type 1 and type 2. How to treat? Yes, Dr. Ruban, you raised your hand.
No, Dr. Khalid, I did not raise my hand.
Okay.
Excuse me, Dr. Khalid.
Yes.
Regarding the use of
Yes.
Yes, regarding the use of radioactive iodine in differentiating type 1 and type 2. Usually patients who take iodine, who take amiodarone already have an iodine overload.
Yes.
And this might interfere actually with the uptake of iodine in the thyroid, even if there's a case of hyperthyroidism.
Yes.
So if you are giving a choice between Doppler and...
Doppler, of course, Doppler.
Doppler,
of course, Doppler. Of course, Doppler.
Yes, you will go for Doppler.
Yes, actually, yes.
Okay, thank you.
But you must know that in type 2, most of cases of type 2, radioactive iodine uptake is near zero. If you find that the radioactive iodine is about 2 to 3%, for example, it mostly type 1. But if it is 0%, it mostly type 2, Actually, coronary flow Doppler is the best one to differentiate between this and this. Actually, in most scenarios, we must do autoantibody and coronary flow Doppler and thyroid radioactive iodine uptake. And after that, in most cases, we cannot differentiate between type 1 and type 2 and deal with a mixed form of amiodarone-induced thyrotoxicosis and give a treatment of type 1 and type 2. And according to the next slides, I will discuss it in more details.
Okay.
How to treat amiodarone-induced thyrotoxicosis? The first question we asked, should amiodarone be discontinued? And as we mentioned previously, and according to the guidelines, this must be individualized and must be done after consultation with the treating cardiologist. According to the etiology of underlying cardiac lesion, for example, if the patient received amiodarone due to the ventricular tachyarrhythmia, there is no trial for discontinuation of amiodarone, and we must treat by antithyroid or corticosteroid. And also the half-life of amiodarone is very long, so even if you stopped amiodarone, amiodarone mainly is stored in the fatty tissue and released very slowly along time, so you must suspect there is no rapid correction of underlying condition or iodine overdosage after stopping of amiodarone. According to the guideline published by the EDA in type 1 and mixed form, stop amiodarone if possible. And in type 2, amiodarone can be discontinued. How to treat type 1 amiodarone-induced thyrotoxicosis is treated by very high dose of antithyroid drug. This high dose of antithyroid drug, for example, if we treat by carbimazole, don't try to give a small dose. You must give about 40 to 60 milligrams of carbimazole daily, and the response for antithyroid drug is very slowly in type 1. And we can increase the response for antithyroid drug by giving sodium perchlorate 1 gram per day for about 1 month to increase the response for antithyroid drug. After that, after very long duration, when the patient become euthyroidase, you must do a definitive treatment by surgery or radioactive iodine. And of course, radioactive iodine is not accepted except if a thyroid scan elevated after stopping of the drug. So most cases need a surgery as a definitive treatment in type 1. In type 2, this is a simple one. Once this is amiodarone, of course, can be continued. We give a high dose of glucocorticoid, for example, prednisolone, about 40 milligrams per day for about 2 to 4 weeks. And after that, in most cases of amiodarone-induced thyrotoxicosis type 2, the patient will return to euthyroid after 1 month. After that, we can taper our dose of glucocorticoid within 2 to 4 months. After remission, we can stop, of course, the corticosteroid and just a follow-up of our patient. In another case, which is a mixed, or we cannot differentiate, is it type 1 or type 2? This is very important because this usually the question in the exam. If you suspect you cannot differentiate, is it type 1 or type 2, you can give post medication, antithyroid drug, plus or minus sodium perchlorate, plus or minus glucocorticoid. So we treat it as type 1 and type 2. After 2 weeks, do free T3 or thyroid hormone in general. If there is a rapid response, rapid normalization of thyroid hormone, you must suspect this case is type 2, not type 1. Type 1 respond very slowly to antithyroid drug, but type 2, a rapid response to oral glucocorticoid. So if you give antithyroid drug with glucocorticoid and after 2 weeks, rapid normalization of thyroid hormone, you must suspect this is a truly type 2, and in this scenario, you must stop antithyroid drug and continue oral glucocorticoid as type 2 and go on. If after 2 weeks, there is no response, T3 is still elevated, T4 is still elevated, so you must suspect this is type 1, so you must stop oral glucocorticoid and taper the high dose of glucocorticoid and continue with antithyroid drug plus or minus sodium perchlorate as a type 1 and go on as a type 1. And of course, you need a definitive treatment with surgery or radioactive iodine. And of course, in any case of this, if the patient receive oral glucocorticoid and no response, you can give antithyroid drug and vice versa in most cases. This is my lecture presented in the previous months in Asyut, and I will go to the
دكتور خالد
Yes, دكتور سفيان مرحبا. انا كنت عايز اسلم عليك بعد ما لمحت اسمك. يا مرحبا يا دكتور سفيان، وحشنا كتير.
والله انت اكثر والله. Just a quick questions regarding the radioactive iodine. What's the problems with the radioactive iodine treatment in type amiodarone induced thyrotoxicosis type 1? Sorry.
Because radioactive iodine, actually to be effective, it needs that radioactive uptake is elevated. And actually, in most cases of amiodarone induced thyrotoxicosis type 1, most of cases uptake is low. So the incidence of uptake by radioactive tracer will be low. So in most cases is not effective except after rendering our patient euthyroid after at least 1 year, actually, Dr. Sufyan. So most cases actually treated by surgery after beginning euthyroid. To treat by radioactive iodine uptake must be normalized at least.
اوكي.
وحشنا كتير يا دكتور يا دكتور سفيان.
والله انت اكثر دكتور خالد، والله انت
مفتقدينك بصراحه، انت والدكتور محمود عزت والدكتور ابراهيم. انا ما اعرفش الدكتور ابراهيم، ان شاء الله المره اللي جايه يكون معانا لو ما كانش معانا.
ان شاء الله. المشكله في التوقيت قاعد صعب بالنسبه لي، لان يوم الجمعه عمل والساعه 5 تكون بدري واجد، يعني نزلت نقعد في العمل.
طب يعني انت عايزها انا اصلا انت عارف المشكله، يعني excuse me, I just speak in Arabic. Some of other colleagues, the time is different, especially for India and Pakistan, I think, and some other localities. So I try to be midway between this and this. Every time I can accept every time actually 5 GMT or 7 GMT or later or more advanced. At least time it is acceptable for me.
Yeah, for me 5 GMT I'm still at work, so maybe 6 GMT or 7 GMT.
Actually, I will ask if it is accepted for everyone. I am with you actually.
Okay, thank you.
Okay. And of course, parathyroid and the calcium and osteoporosis, this is the area of Dr. Sufyan. Dr. Sufyan, one of the pioneers in the management of osteoporosis and the dilemma of osteoporosis and how to use the bisphosphonate and this drug. Dr. Sufyan, one of the pioneers actually in this area. So, inshallah, in the area of parathyroid and calcium, Dr. Sufyan, one of the cornerstone for solving these questions.
مش لدرجة دكتور خالد، بارك الله فيك.
This is just a few slides from Oxford Handbook about the amiodarone and thyroid. I think I cover all of them. This is the daily requirement of iodine is 150 to 200 microgram per day. And of course, the half-life of amiodarone, it is 57 or 52 days. And of course, here he mentioned that the thyroid abnormality occur in about 50% of patients. But in this table, he mentioned that it is less than this one. Actually, I will show this table. He mentioned that the arrangement of thyroid function test is about 25%. And in other references, they mentioned that it is about 18%. So as we said, about 13% develops hypothyroidism, or 2% presented by amiodarone-induced thyrotoxicosis. And don't forget that AIH, it is amiodarone-induced hypothyroidism, AIT, amiodarone-induced thyrotoxicosis. And of course, the hypothyroidism is commoner in the female. And of course, he mentioned that dronedarone is a non-iodinated benzopyrene derivatives like amiodarone, but less effective than amiodarone actually in clinical practice. Pathogenesis, of course, hypothyroidism, high dosage of iodine can inhibit thyroglobulin iodination and thyroid hormone synthesis by what is known as Wolff Chaikoff. Off means hypothyroidism. Off means decreases synthesis of hypothyroidism. Just to memorize Chaikoff versus Jude Basid. And another one, iodine-induced hyperthyroidism is susceptible individual, which is Jude Basedo phenomenon. Amiodarone also inhibit the conversion of T4 and T3, block the conversion through the adenine enzyme type 1. And so this is lead to decrease the level of T3 and increase the level of TSH as an initial thyroid function test in a case of patient receive amiodarone. And of course, as we said, the type 1 amiodarone thyrotoxicosis, this is a true hyperthyroidism, so treated by antithyroid drug, and type 1, which is a direct toxic effect by amiodarone, which is thyroiditis, and this is treated by corticosteroid as some of thyroiditis. And this is, as we mentioned previously, what occur in the initial period after initiation of amiodarone. Free T3 will be low, a TSH transient increase, a T4 modest increase because the conversion of T4 to T3 is blocked. So most of T4 will be retained, and of course, reversed T3, the opposite as the free T3, reversed T3 will be increased. After 3 months, TSH will be normalized. The free T3 will low normal, and the free T4 will more than mildly elevated. And this is how to differentiate. I think this table I covered it in the previous slides. The most important one, Doppler increase or normal in type 1, reduced in type 2. Don't forget that amiodarone disease type 2, this is the commonest one. About 90% of cases of amiodarone disease was type 2. Type 1 is in less than 10% of cases. And of course, goiter is present in type 1, doesn't, because there is underlying thyroid pathology. If you see thyroid nodule, you must suspect it is type 1. If normal thyroid, underlying thyroid ultrasonography, mostly it is type 2. Thyroid autoantibody is positive in type 1, negative in type 2, but this is not a solid and not 100% rule, because autoantibody, as we said previously, present in about 30% in general population. Thyroglobulin is normal or slightly elevated in type 1, but it's very elevated in type 2. Don't forget interleukin 6 is elevated in type 2, but it will be normal in type 1, and also selective protein is positive in type 2, negative in type 1, but this is not available interleukin 6 in most localities. Treatment, of course, as we mentioned previously, steady achieved slightly elevated T4. This is how to manage hypothyroidism. If TSH is more than 20, you must treat. If there is over hypothyroidism, we must treat. If TSH is between 5 and 20 units per liter, judgment to treat by levothyroxine according to the clinical ground, according to the symptoms, according to the manifestation, according to the underlying thyroid pathology. If it is Hashimoto, then you must treat. If not, you can treat or not according to the another scenario. For type 2, as we mentioned previously, this is very important. This is the most important one, as we mentioned previously. If there is doubt, of course, type 1 treated by antithyroid drug, type 2 treated by corticosteroid. If there is a doubt, so you can give 40 milligram of carbimazole plus 40 milligram of prednisolone daily for 2 weeks. After that, measurement of serum T3. This is a reasonable strategy. If there is a reduction by about 50% compared to the pre-treatment level, then carbimazole is stopped as the diagnosis is type 2. If no normalization of T3 or reduction by more than 50%, so it is type 1, stop prednisolone and continue antithyroid drug. And here is radioiodine is not usually effective because of reduced uptake by the thyroid gland, reflecting the iodine load associated with the drug. Surgery remain very successful for treatment of type 1. And of course, lepropranolol can be used in a case of, is not appropriate to use propranolol with a cortisone because it may cause bradycardia or heart block. Of course, the potassium perchlorate inhibit the iodine uptake by the thyroid gland and reduce the intrathyroid iodine and render cyanoamide or antithyroid drug more effective. A dosage of potassium perchlorate 1 gram daily together with the carbimazole for about 2 or 3 to 4 or 6 weeks.
Dr. Khalid,
yes.
May I just know regarding the surgery options, when will we consider surgery for this issue?
After normalization of thyroid, actually we treat by antithyroid drug and by potassium perchlorate or sodium perchlorate for 1 month. And after rendering the patient euthyroid, you must refer your patient to definitive treatment either by the surgery, this is the most logic one, or radioactive iodine if applicable for your patient. In type 1, if you stop antithyroid drug, there always a relapse. But in type 2 with corticosteroid, there is in most cases spontaneous remission can occur.
Dr. Khalid, it's 1 month or 1 year?
Which one? 1 month for potassium perchlorate. Potassium perchlorate is given for 1 month, 1 to 1.5 months. But the antithyroid drug mostly given until the patient rendered euthyroid. This in most cases take about 1 year, at least.
Dr. Khalid, can you go back to that slide where there is the increase in the reverse T3?
Yes, this one.
Yes.
This is just what happened during the initiation of antithyroid drug. Actually, reverse T3, this is usually the opposite than free T3.
Okay.
Dr. Khalid, when we consider radioactive iodine as a treatment for type 1, or when we consider surgery, is there any like a
according to the thyroid uptake? يعني for example, after rendering your patient euthyroid, for example, after 1 year, to do radioactive iodine uptake. If it is elevated or it is actual upper normal, so a radioactive iodine ablation may be effective in this case. If still radioactive iodine is low or not normalized, so the surgery is the best option.
Okay, thank you.
This is the side effects of, as we mentioned the previous, for amiodarone. Of course, the corneal microdoses in about 100%, anorexia and the nausea, photosensitivity, blue-gray skin discoloration, ataxia, tremor, peripheral neuropathy, liver function derangement, abnormal thyroid function test, as we mentioned, interstitial pneumonitis, and also cardiac arrhythmia can occur in about 2 to 3% of cases receiving amiodarone. And this is the dosage of a drug from Oxford Handbook. And dosage of a drug here for type 1, and we repeat carbimazole from 40 to 60 milligram per day, or propylsulfuracil in a high dose, in combination if necessary with potassium perchlorate 1 gram per day for about 2 to 6 weeks of possible discontinue amiodarone. And of course, step 2, definitive treatment, radioiodine treatment or thyroidectomy. This is the definitive treatment. But type 1, just prednisolone for 40 milligram per day, in most cases from 2 to 3 months, follow up after euthyroidism, follow up for possible spontaneous progression to hypothyroidism, but this is actually not very common. Now I end my presentation from the Oxford Handbook, and just a few questions from the previous exam. This is from 2016. A question, they asked about the question: a hypothyroid patient taking 300 microgram levothyroxine but still having a subclinical hypo. The TSH is elevated, the T4 is normalized. So what do you think about this scenario?
Compliance, non-compliance.
Yes, non-compliance. The non-compliance, especially in the T4, the upper normal of T4 about 12. This is, or even if T4 is elevated, this is a typical picture of compliance. So we must check the compliance before go to the thyroxine absorption test and so on. Another question asked about hypothyroid lady with high cholesterol, unable to tolerate even a small dose of levothyroxine, and said she does not want her thyroid treated. What to do next? Here, someone mentioned that change to liquid thyroid or start statin. What is your opinion? This is not our exam, so this is just I picked this recall from Facebook paper page like this.
I think liquid thyroid.
I
Because
also
it
think
will
liquid
not be
thyroid.
normalized.
But I think, as the patient said, must be. I think it must be respected. The patient said she does not want her thyroid treated. I don't
Khalid,
know
side
what is
effect
applied
of
in the UK.
no, the side effect of thyroid is not only on the is not only elevated statin. It's
Yes.
it's the so
Yes.
many side effects.
Yes.
We don't have to take care of the statin only. We have to take care of the overall side
Yes,
effects.
yes,
Overall
I am with you. But what is it to respect the patient
Autonomy of the patient.
Yes, I think this must be respected actually, and also I
Patient can
didn't
decide
know.
regarding her management plan.
And I think even liquid thyroid, the same component as levothyroxine tablets. I think the same side effects if it is available. I don't actually know the exact scenario and how to treat, but actually in this scenario I am with this starting statin. I don't know is it the correct one or not. Actually, I don't know. If anyone has a suggestion, or we can discuss it.
Well, I think she needs to take thyroxine. I think you need to. Well, there's no other treatment. Even the statin wouldn't help. So either. So why she doesn't want to be the thyroxine to be treated? And this
actually,
is the
I don't
discussion
know. Is it a side effects of thyroxine, which is very rare
yeah.
or not? I don't know.
So this is where if she has developed any side effect, so we need to change the company, change the filler,
yes.
or try at the last options. I think you need to change the company many times. If there is no response, you give her that one with the gel. I think it's only available in America.
I think the table mentioned in the Oxford Handbook, the constitution of every company, trade name, and so on. Maybe for this, maybe.
Yeah, maybe.
This is a repeated
right.
question, a very repeated question. Amiodarone-induced thyrotoxicosis, type 1 and type 2, and how to treat it, how to differentiate, and how to manage. This is a repeated question. You must suspect at least 2 questions about amiodarone-induced thyroid dysfunction in every exam. Here, a question asked about amiodarone-induced thyroiditis type 1, history of thyroid disease, and how to differentiate. As we mentioned the previous, this is how to differentiate between type 1 and type 2. And this is algorithm from this table from the guideline published by ETA in the previous year. And this is the same how to manage, and this algorithm I mentioned the previous actual, and how to treat type 1 and type 2. Another question, amiodarone-induced thyrotoxicosis type 1, history of thyroid disease, positive for anti-TPO, and normal to increase the uptake scan, of course treated by carbimazole, plus or minus potassium perchlorate or sodium perchlorate. Another one, a question in the same year, amiodarone-induced thyrotoxicosis type 2, this is a destructive, and of course the antibody is negative here, and they reduce the uptake and they treated by steroid, high dose steroid. Here a question in this year, breast cancer, endometrial cancer, thyroid cancer, you must suspect Cowden syndrome, which is B10, which is autosomal dominant. This is a repeated question. Breast pathology, endometrial pathology, thyroid pathology, you must suspect Cowden syndrome, which is caused by inactivation of B10, which is a tumor suppressor gene. And this is the Cowden. Another question asked about the hypothyroid planning pregnancy, TSH target. TSH target in any patient with planning pregnancy, this is a repeated question actually in the previous year and the previous one. Every year this question is repeated. A target of TSH is less than 2.5. A target of TSH in a hypothyroid female planning for a pregnancy, TSH is less than 2.5. A question recall from 2017 asked about the question about amiodarone use cytotoxicose given carbimazole and steroid, and after 4 to 6 weeks his TSH decline. Which one to stop? TSH is normalized actually. Which one to stop? Rapid normalization of TSH.
Carbimazole.
Carbimazole.
Yes, it is a type 2. So it is type 2, so we must stop carbimazole. And this is the same guidelines. This is pregnant with previous abortion, TSH is 6, is 5. Pregnant with previous abortion, her TSH is 5. How to manage? How to give? Of course, we must give.
Increase the dose of.
Yes, if she received already on thyroxine, we must increase the dose. If not on thyroxine, we must give thyroxine. And this algorithm is very important in spite if it is published by American Thyroid Association, but in a clinical practice, this algorithm is very important, and we will try to check it. In high-risk women, in a case of infertility, check TSH as soon as the pregnancy confirmed with reflex TPO if TSH is more than 2.5. In this case, TSH is the most important one, and to do anti-TPO if TSH is more than 2.5. If TSH is low, so this is a thyrotoxicosis or gestational hyperemesis gravidarum or gestational transient thyrotoxicosis or a grave disease. This is another issue. If TSH is low, less than 0.1, this is we must investigate as a case of thyrotoxicosis. If TSH,
Dr. Khalid,
yes?
Dr. Khalid, is it for the all females or is it for only for hypothyroid cases? We have to keep the TSH in the lower normal range and then in the first trimester of pregnancy 0.1.
For high risk, actually for high risk. For example, repeated abortion, history of thyroid disorder or hypothyroidism. But if there is no repeated abortion, leave it as it is. Except if there is a concern from the pregnant female itself, she suggests that she needs to be treated as a hypothyroid one. Of course, if TSH is between 0.1 to 2.5, this is a first trimester specific reference saying this is euthyroid, no further workup. But if TSH is more than 2.5, if it is more than 10, we must treat. If it is between 2.5 to 10, we differentiate between anti-TPO positive versus anti-TPO negative. Of course, if anti-TPO is positive, we must treat if it TSH more than 10, but if it TSH between 2.5 to 10, and not to 10, to upper reference range of the normal, in most laboratory until 4, TSH between 2.5 to 4, consider a treatment with levothyroxine because an anti-TPO is positive. So in any case of female, an anti-TPO is positive and the TSH is more than 2.5, consider treatment. In any case of TSH more than 2.5 and TPO is positive. But if anti-TPO is negative, a TSH more than 10, consider treatment. A TSH between 2.5 and 4 or upper reference range of the normal, no indication for treatment because anti-TPO is negative. So in American guideline, American Thyroid Association guidelines, they does not recommend the management of euthyroid female TSH more than 2.5 to 4 and the anti-TPO is negative. They recommend to treat if TSH is more than 4. Consider treatment if it is more than 4 to 10. If more than 10, must treat. Okay, this actually is simple algorithm, and this is the practical algorithm in our clinical practice. Okay.
Okay. Dr. Khalid, just in people who are already hypothyroidism and got pregnant already. So in the first trimester, we don't usually target the TSH, right? Because the TSH is usually low.
Yes.
As a physiological change. Is that correct, or am I?
Yes, but at least we will target as 0.1 to 2.5. In general, we must increase the dose of thyroxine in any patient, female patient who is stable in some dose. We must increase the dose by 2 doses per week. But correct, our target is still 0.1 to 2.5.
What about this physiological change that the TSH will go low?
Yes, this is the physiological. Actually, Dr. Sufyan, the normal reference of TSH is 0.5 to about 4.2 or 5 according to the reference range. So a lower limit of TSH is decreased from 0.5 to 0.1. This is a physiological change, and still TSH may be low than this, and still a normal pregnancy as mentioned by the guideline. But when you treat, this is your target.
Okay. 0.1. Okay. Yeah, thank you.
Okay. And this is a recall from 2018. Anyone, I just collect some question, and anyone want to read this question and answer it. This question actually is repeated in every exam. This question by this scenario is repeated a lot, at least in the previous 2 years. Okay. Anyone want to read this question?
5 patients were referred to rapid access thyroid clinic. Only 4 slots were available in the following month. Which patients can safely be deferred to later clinic? 16-year-old boy with thyroid nodule, 39-year-old woman with a slowly growing thyroid lump and palpable cervical lymph node, 44 woman with a history of sudden onset pain in the thyroid lump, 45 woman rapidly enlarging painless goiter, 67 man with a goiter and hoarseness of voice.
Which is high risk, which is low risk of malignancy?
A and E, high risk.
Number one.
He asked here, he asked which is the lowest one of malignancy. One is low. Only one. All of them are a high risk of malignancy except one.
C.
Sudden onset of pain.
B.
Yes, there's a hemorrhage in cyst.
Yes. B, actually B is not correct because there is a palpable cervical lymph node. A palpable cervical lymph node, one of the alarming feature, increase the risk of malignancy. Thyroid nodule in the young, less than 20 years, is a risk of malignancy. Hoarseness of voice is a risk of malignancy. Rapidly enlarging painless goiter is a risk of malignancy. But sudden onset pain, it means a hemorrhage in a cyst, which is a benign feature, not a malignant feature. So C is the correct one. Sudden onset pain in the thyroid lump, this means a hemorrhage inside the cyst. This is a benign, not a malignant feature. All of them are a malignant feature except C. Okay. Another question.
So patient with thyroid nodule 2.5 centimeter, TSH 0.01, T4 high, T3 high, anti-TPO antibodies positive. What's the next step? Thyroid uptake scan, fine needle aspiration, thyroid scintigraphy, surgery, and antithyroid drugs.
Thyroid uptake scan.
There is a thyroid nodule. TSH is thyrotoxic. The anti-TPO is positive. What is the best one?
Thyroid uptake scan.
Uptake or scintigraphy?
What's the difference?
This is an uptake. Just give a number. The uptake of thyroid is increased but thyroid scintigraphy show the anatomy and morphology of the nodule. Is it cold, hot, or warm nodule, or diffuse uptake for the thyroid, or low uptake for no uptake for all the thyroid? The thyroid uptake just give a number, but thyroid scintigraphy give a morphology of the thyroid.
So thyroid scintigraphy.
I am with Dr. Ruban. Thyroid scintigraphy is the best one because here there is a thyroid nodule. Is it a toxic nodule or not? The only one
we need to know
to give a thyroid nodule uptake is hot or cold or warm is thyroid scintigraphy. A thyroid uptake by name, it will give a high uptake, which means maybe toxic nodule, maybe toxic Graves' disease, maybe toxic multinodular goiter, and so on. Just will give us a number like, for example, 10%. 10%, which means in our locality, high uptake. So toxic nodule will give 10, Graves' disease will give 10, multinodular toxic goiter will give 10, and so on. But thyroid scintigraphy will give us the nature of this nodule. Is it a hot or cold or warm nodule? So a thyroid scintigraphy is the best option here. But if we differentiate, modify some words, for example, remove anti-TPO and give TRAB is positive.
Fine needle.
So yes, if TRAB is positive, so we know that TSH is suppressed due to the underlying Graves' disease. But for thyroid nodule, there is no need for thyroid scintigraphy, because even if you do thyroid scintigraphy, this nodule will be a cold nodule, and we must go to the fine needle aspiration biopsy. This is a different in some scenarios. In this scenario, the best option is thyroid scintigraphy. If we give an anti-TRAB is positive, the best option is fine needle aspiration biopsy. And this question is presented in exam lab.
Why not ultrasound, Dr. Khalid?
Of course, there is no ultrasound. Of course, in any case of thyroid nodule, the thyroid ultrasonography is the best, is the initial test to do after TSH or before TSH. And after thyroid ultrasonography, the next one of these options. Actually, there is no ultrasonography. But if they mention ultrasonography, I think ultrasonography as a non-invasive procedure is the best one if it is available here. Actually, in clinical practice, thyroid ultrasonography is done in every case of thyroid nodule. After that, TSH. After that, thyroid scintigraphy or fine needle aspiration biopsy, according to the scenario.
And what's the value of anti-TPO positivity here? So what does that mean?
Actually, does not mean anything. But it may be conflicting someone between an anti-TPO and the TRAB. The TRAB is not like an anti-TPO. The TRAB is positive in Graves' disease, but an anti-TPO is positive in a lot of thyroid disorders.
Yeah, but it's positive in Graves as well, so that's
yes,
why.
in Graves and in Hashimoto's thyroiditis and in general population and the relative of the patient, in a lot of disorders, Dr. Sufyan, not pathognomonic for Graves actually, and this is the most important hint.
Okay.
And this is a question. Okay.
So female pregnancy in 8 weeks, no manifestation of thyroid disorder, TSH undetectable, T4 mild elevated, TRAB, TSH receptor antibody is positive. What is the management? IUD, propylthiouracil, carbimazole, observation or surgery?
Propylthiouracil.
Propylthiouracil, 2.
I am with you actually, propylthiouracil, but don't forget in mild Graves' disease,
Observation.
Mild Graves' disease is not is a benign lesion actually. During the pregnancy is a benign lesion. Risk benefit ratio must be put in our mind when we treat a patient like this with a propylthiouracil. Of course, iodine is not is contraindicated during pregnancy. Carbimazole is not appropriate in the first trimester. Surgery is not appropriate. So the correct one in propylsulfonyl versus observation. Actually, in the guidelines, actually in the guidelines they mention that mild grave disease is a benign lesion and can just treated by observation. But in this scenario, is it the correct one? I don't know. Propylsulfonyl may be an option. Observation may be an option. In our case, there is no manifestation of grave disease. I am with observation, but I don't sure is it the correct one or not.
لا correct دكتور خالد.
يعني برضو يعني ايه
up to date المايلد and asymptomatic hyperthyroidism no need for anti-thyroid medication.
I am with you, and this is a recommendation by the guidelines published by American Thyroid Association, and I can show. I think in the previous session I showed the slide. Mild hyperthyroidism have no bad impact on a pregnancy and on fetus. But the propylsulfonyl actually it is categorized by FDA as category D, so some harm can be occur from propylsulfonyl during the pregnancy.
Yeah, Dr. Khalid,
yes.
There is also a graph in which there is the mild, hyperthyroidism, subclinical hyperthyroidism also. There are the chances of 30 to 50% patients can go into the regression, and 10 to 20% only can go into the progression.
Yes.
So what to do? We should evaluate the patient after 3 months with the thyroid function test again, and to see what is it.
Yes, but actually during the pregnancy, Dr. Ban, it is better to evaluate your patient after 2 to 4 weeks, 2 to 4 weeks actually, to do a repeat thyroid function test, and according to the lab. In most cases, especially this is a recommendation by the guidelines. If any patient with thyrotoxicosis controlled with a small dose of carbimazole, 5 to 10 milligram before conception, and get pregnant, we can try to withhold the anti-thyroid medication and repeat thyroid function after 2 to 4 weeks, and decide to proceed with the propylsulfonyl or just observation. This is just for a patient, female patient, who rapidly controlled with a small dose of anti-thyroid drug. Because most cases will need no treatment in the first weeks of gestation, and then even if needed some anti-thyroid drug dose mostly will be decreased in the second trimester, and most cases will stop anti-thyroid drug in the third trimester, but relapse will occur after postpartum.
But in case of mild Graves' disease, in elderly, we need to treat it at the beginning only, because there are the chances of arrhythmias.
Yes, of course, as recommended by the guidelines, subclinical hyperthyroidism, is it a grade 1 or a grade 2? It is very important. Of course, it is sustained suppression of TSH with normal thyroid hormone. This, if the age is more than 65, we must treat, especially even if the patient is less than 65 and cardiac or osteoporosis or symptomatized, we must treat. But actual subclinical hyperthyroidism, no need for treatment during the pregnancy.
Okay. So observation is the answer.
Yes, I am with actually in the previous case with just observation, not a propylsulfonyl. This is just a question about hypothyroidism. Okay. This is a female pregnant in the second trimester in thyroxine 100 microgram. TSH is elevated. The free T4 is low than normal. How to manage?
Increase thyroxine to 150. You told about
this. Yes, this is yes. Actually, the guidelines they recommend, or all authorities recommend, to increase the dose between 25 to 50%. But actually, as Lifriti-4 is low, and of course TSH is more than 10, we must increase the dose by the maximum recommended dose to 150. This is a patient with amiodarone, no symptoms of hypothyroidism, with TSH is mildly elevated. Lifriti-4, I don't know, I think it is normal. What is the next step? Give a small dose of thyroxine or observation or serial radioactive iodine or corticosteroid. Actually, it is a mild hypothyroidism and Lifriti-4 is normal and no symptoms, so observation is the best option here.
What means by 5, Dr. Khalid?
Which one?
CS.
CS corticosteroid. Corticosteroid.
Okay.
This question asks about Graves' ophthalmopathy, picture of elderly male with a history of Graves' disease and received radioactive iodine since 3 years and presented nowadays with unilateral eye swelling. Which test, which next test, CT orbit or TRAB or anti-TPO or anti-TG or thyroid scan?
CT orbit.
Yes, I am with CT orbit, and this is a lot of debates in the previous exam between us in the interactive session like this. Is it CT orbit or TRAB? At the time, I am with TRAB actually, because in every case, if you suspect Graves' ophthalmopathy, go to the TRAB. If you don't know it is a Graves' ophthalmopathy or other thing, go to the TRAB. But I think there is a history, previous history of Graves' disease, and the patient received radioactive iodine, so we must suspect that TRAB is still positive after 3 years. So I think it is a unilateral eye swelling, so I think CT orbit is the best one.
But sir, Graves' disease can also, I mean, Graves' ophthalmopathy can also present with unilateral eye swell.
Yes, but it is in about 10%, not very common. But at least the CT orbit, the most important finding by CT orbit is to exclude another organic lesion which compress the eye globe to out and so on.
Okay.
I think this is the last question today, inshallah. I hope if, inshallah, in the next Friday, we will continue thyroid. If Dr. Ibrahim Al-Ali is ready for thyroid cancer, we will give thyroid cancer. If not, I will give, because Dr. Ibrahim prepare, actually, he tell me that he prepare thyroid cancer. This is the last topic in the thyroid chapter: thyroid cancer, differentiated thyroid carcinoma, anaplastic, lymphoma, and the most important session, inshallah, questions, solving question. So I think I will prepare it with Dr. Ibrahim in the next Friday. Mostly I will with you to solve some questions. I will solve, inshallah, Dr. Atul book, exam lab, and some of question from study BRN or another source. So we need a lot of interactive in the next session. And inshallah, Dr. Ibrahim Al-Ali in the next or after 2 weeks from today, he will give us a very interactive session about thyroid cancers, inshallah, and how to manage. If
Dr.
anyone
Khalid,
has a question about thyroid,
Dr. Khalid, can we discuss 2 questions here?
Yes.
One related to amiodarone.
Yes.
One is from the study PRN, question number 2.
Okay, I can will show it from my program.
Yeah, I know you have everything in your program. Study PRN, question number 226.
Okay, just study BRN. Which one?
Question number 226. 226.
Okay. 226.
20.
Okay.
Yes.
Okay, this one. This one?
No, this is 230. 226.
Oh, okay, this
Yes,
one.
this one.
Okay, this one.
Yes.
I can show it. Okay, you can read it, Dr. Ruben.
Okay. A 66-year-old male with a past history of ischemic heart disease and episodes of ventricular tachycardia has been treated with Amiodarone 200 milligram for 2 years. His VT is well controlled. Ventricular tachycardia is well controlled on this treatment, but laterally he presents with fatigue, anxiety, and weight loss. On examination, he has a fine tremor of the outstretched hands, a pulse rate of 88 beats per minute, but is receiving beta blockers, has lid lag, but no goiter is palpable. His thyroid function tests reveal free T4 55, TSH less than 0.02, thyroid antibodies negative. Which of the following is a likely diagnosis? Amiodarone-induced thyrotoxicosis type 1, Amiodarone-induced thyrotoxicosis type 2, Decurions thyroiditis, Graves' disease, Hashimotoxicosis.
Which one?
Two.
This is 2, type 2.
Yes, yes, I am with you, type 2.
Yeah,
Because
now I have yeah,
yes.
because same question is in the exam lab, 146.
Exam labs, this one. Okay, this okay. In the first, this is actually thyroid autoantibody is negative. A lead lag is not pathognomic for Graves' disease, actually. A lead lag occurs in any case of thyrotoxicosis, and this is very important. And of course, the most common cause of amiodarone-induced thyrotoxicosis type 2. So this is actually the most common one is type 2. Let's go to the exam lab question.
Exam lab question 146.
146. 46. This one?
Yes.
Okay.
Now somebody else will read it.
Yes, I can read it. The difference here, this is the same patient who admitted with right lower lobe pneumonia.
Antibody positive here.
Okay, no, antibody is negative, still negative. It is 32, and the positive is more than 50. Already in the amiodarone for AF, routine thyroid function tests were performed. TSH is low, but low is just 0.3. Free T4 is mildly elevated. Free T3, this is very important, is normal. Free T3 is normal. Anti-TPO is negative. What is the most appropriate interpretation of the thyroid function test here? Is it amiodarone effect on the euthyroid patient? It is amiodarone-induced thyrotoxicosis type 1 or type 2 or subclinical amiodarone or Wolff-Chekhov. In the first, Wolff-Chekhov cause hypothyroidism. This is not correct. Okay, then next one by exclusion. So is it type 1 or type 2 or subclinical amiodarone-induced thyrotoxicosis? Which one? T3 is normal. So
amiodarone effect in a
this is
patient.
actually, this is the best one. Actually, this is amiodarone effect. Why?
Inhibition
Because
of deiodinase.
this is one, but actually in the amiodarone-induced thyrotoxicosis type 1 and type 2, T3 will be elevated.
Okay.
T3 will be elevated. In type 2, T3 elevation is more than T4 actually, or T3 over T4 ratio is more. But in both condition, type 1 and type 2, T3 will be elevated. And another clue for this question, TSH suppression is just low not low normal,
Just below the low normal,
decreased than in normal. But in the previous scenario, TSH is less than 0.1. This is the suppressed TSH. So in mild decrease for TSH, we must suspect a maybe amiodarone effect on the euthyroid patient. Okay.
Okay, okay, Dr. Khalid.
Exam lab, actually, in everyone, exam lab, one of the most important thing to solve. Exam lab in every year, at least 30 question from exam lab. In every, at least in the previous 2 exams, actually, in the previous 2 exams, about 30 question typically from the exam lab. Exam lab just
Dr.
contain
Khalid,
200
in
questions.
exam lab, these are scattered questions. Can
What?
we, these are, I mean, topic wise, I mean, in the study PRN, we get the topic wise questions.
Yes.
So it becomes easy when we are studying, I mean, thyroid, when we are studying any other topic, we can solve those questions. But in exam
Yes.
lab, very much scattered. That's the main drawback in this.
Yes, there is no comment, just it is a question and we can solve. So inshallah, in the next presentation, we will solve exam lab and a toolbook, all a question, thyroid, a toolbook and exam lab, all a question. Actually, in the exam lab, I think just a thyroid question, just 32 question, and from the toolbook, best of 5, I think it is 62, so it is 100. I will select the most important question to solve some question from study BRN. Inshallah, I have 2 sessions in the thyroid to solve the questions, and Dr. Ibrahim Al-Ali have a session about the thyroid cancer. So we have 3 sessions remaining in the thyroid, and we will start the adrenal disorder after thyroid, inshallah. So if anyone has a question today, I am with you. Okay, so let's say goodbye to everyone. Dr. Asma, Dr. Ruben, Dr. Saleh, Dr. Aisha, Dr. Ala Abdel Hafiz. Welcome, Dr. Ala, Habibi, Dr. Ala. Dr. Nobel, HP, Dr. Salwa, Dr. Samsung, someone Samsung.
Dr. Khalid.
Okay.
Dr. Khalid.
Yes, Dr. Asma.
Can I ask you your opinion about one case as a consultation for me?
Yes, actually, yes.
Female patient, 33 years old, completely healthy before, presented by cardiac arrest, dyspnea, short of breath, and cardiac arrest. Diagnosed as pulmonary embolism. The patient has no history of chronic illness, just patient on oral contraceptive.
Yes.
The patient in ICU, I don't know the reason for thyroid profile. I think the patient on mechanical ventilator and fee delayed in weaning. Ask for thyroid profile, T3 low, T4 low, TSH high.
Elevation of TSH, how much?
7.
7, I think this is the sick euthyroid syndrome, low T3 syndrome. This is a normal physiological response. Low T3 with low T4 with mild elevation of TSH. This is the typical manifestation of sick euthyroid. In a patient,
in a recovery state, I think it is in a recovery state. I think
even
okay.
Yes, Dr.
I think euthyroid 6 syndrome start by low T3. Low T4 is a bad prognosis.
Yes.
But during recovery, TSH can increase to some extent, mild extent. On recovery, the patient on inotrope and the heparin, which means the TSH may decrease.
Yes.
في برضه سيناريو تاني ان البيشنت developed
don't forget that the heparin will increase the free thyroid hormone, which can reflect in the TSH. And also, sick euthyroid syndrome will affect the T3, T4, and TSH. Dopamine, even in inotrope, will affect the TSH. Corticosteroid, which sometimes to be given to patient like this, will affect the thyroid function. The end result of this is thyroid status is not very important to solve, because even in subclinical hypothyroidism or overt hypothyroidism like this, a treatment has no benefits, and also has no impact on the thyroid. Just as you said, it will give us this patient has a bad prognosis. Actually, your patient had a very bad prognosis as arrested and ventilated, and weaning difficulties in the weaning.
A debate يعني some consultant
recommend to treat.
Yeah, already start levothyroxine.
There is some papers. The most important one published by the famous endocrinologist de Groot. De Groot, one of the largest endocrinologists over the world. And de Groot recommend the management of sick euthyroid syndrome by levothyroxine. Actually, he is the author, the main author of the largest book in endocrinology, adults and pediatric endocrinology. This is the very big reference in endocrinology, and he is the main author, and also he co-author in the Harrison textbook of endocrinology and a lot of papers. Actually, there are a lot of debates about to treat sick euthyroid by levothyroxine or not. Some schools recommend to treat because they mentioned that, but you must know that there is no randomized controlled trial between treatment and no treatment. But actually, the schools or the professors who don't recommend the treatment, they mentioned that sick euthyroid syndrome, this is a physiological change to protect the body from thyroxine. So they don't recommend to treat it. Another one recommend to treat it as it is hypothyroidism, and T3 is not available in a much in a valuable manner, or so recommend to treatment. Actually, I am with no treatment of subclinical hypothyroidism or sick euthyroid syndrome, especially for this patient.
Yes, especially this patient developed acute kidney injury after CT angio. And the thyroid function in acute kidney or chronic kidney
can be
disease
affected actually.
كان يعني TSH elevated وال T3 وال T4 low. But the difference between ال euthyroid 6 syndrome وال kidney injury اللي هو ال reverse T3. Reverse T3 increase in euthyroid 6 syndrome and increase in chronic kidney disease.
Yes, but I think the pathophysiology of the case, oral contraceptive pills, antiphospholipid may be one of the cause for pulmonary embolism, and this dilemma. I think you must search for this etiology of DVT and so on. And I think thyroid is the last organ to included in this management for this patient. All of us hope that your patient pass from his condition. إن شاء الله الأمور تعدي على خير ودعوات الجميع.
إن شاء الله. شكرا يا دكتور خالد.
ربنا يبارك فيك يا دكتور خالد.
Thank you, Dr. Khalid. Your session is very helpful.
Thanks for everyone. Okay. See you later إن شاء الله in the next Friday. دكتور علاء، شكلك أنا سامع صوتك يا دكتور علاء. وحشني.
ايوه ربنا يخليك يا دكتور.
عامل ايه يا دكتور علاء؟ انا لسه منتبه لك
باين. افدتنا كتير الحقيقه.
ربنا يبارك في حضرتك، ربنا يبارك في حضرتك. ان شاء الله ان شاء الله in the next Friday we will solve some question from a lot of question on the thyroid topic from other sources.
دكتور خالد، يعني لو يعني حاول ان حضرتك تاخر الميعاد شويه.
والله as I said previously، انا بالنسبه لي وقلتها للدكتور سفيان وكلكم يعني تعزوا عليا، الميعاد اللي تحبوه انا ما عنديش مشكله فيه. يعني لو تحبوا وخر ما عنديش مشكله، بدري ما عنديش مشكله. يعني اوريدي انا يوم الجمعه فاضي ما وريش حاجه. لو عايزينه الساعه 12 ما عنديش مشكله.
لا يعني عشان الجميع يبقى مستفيد ما عندناش مشكله، بس يعني لو ساعه متاخر شويه يبقى
طب اوكي. يبقى خلاص بدل ما نخليها 5 GMT نخليها 6 GMT. اوكي
يا ريت.
طب اوكي that's okay from the next Friday ان شاء الله 6 GMT. اصل هي المشكله عارفه في بعض الناس from India and another locality يعني الفتره اللي فاتت بالنسبه لها هذا الوقت الساعه 6، يعني احنا كنا بنشتغل 9 على فكره في رمضان اللي فات وكده المحاضرات ونقعد لحد الساعه 2، بس كان المشكله ان بالنسبه لهم الساعه 9 تمثل الساعه 2 3 بالليل، منتصف الليل. فمشكله بالنسبه لبعض الناس، اما بالنسبه لنا لا، انا بالنسبه لي كل الاوقات اللي تناسبكم تناسبني طبعا.
عموما احنا يعني بنستمتع بالمحاضره سواء مسجله او حاضرينها.
ربنا يبارك في حضرتك، ربنا يبارك في حضرتك. دكتور ربان، الدكتور ربان بالدور هم بيقولوا ايه او كده. So just we will finish Dr. Ruban and see you later inshallah in the next Friday.
Yeah, thank you Dr. Khalid. Thank you for this interactive session.
السلام عليكم.
عليكم السلام.
السلام عليكم.